Very good afternoon to all of you and welcome for this webinar on cardio-diabetic update. We have excellent speakers for today's webinar, which is very important in day-to-day practice. Thank you.
Good afternoon, everybody. Welcome from IMA Pune. Thank you, President Sir. I take this opportunity to introduce our first speaker of the day, Dr. Manoj Durairaj. Dr. Manoj Durairaj is a pioneer in heart transplant surgery in Pune. He has done his fellowship in advanced cardiac surgery. Dr. Durairaj is President-elect of Indian Association of Cardiothoracic and Vascular Surgeons. He is also Director of Marian Cardiac Center and Research Foundation, East Street Camp, Pune. Dr. Manoj Durairaj has done MS General Surgery from the prestigious AFMC Pune with gold medal in Pune University, MCH in Cardiac Surgery from the most premium institute, AIMS, New Delhi. Dr. Durairaj has completed his advanced fellowships in bypass surgery under Professor Brian Buxton, University of Melbourne, and then he started his practice in Pune. He has been practicing as a consultant heart surgeon since last 16 years. Dr. Manoj Durairaj is director at Marian Cardiac Center, East Street, Pune, where he has his consulting room. He is a senior consultant cardiac surgeon at Ruby Hall Clinic, NM Wadia, Jahangir, Sahyadri Hospitals, Pune. He is the first cardiac surgeon in Pune to be elected as Fellow of American College of Cardiology. He is also an executive member of Society for Heart Failure and Heart Transplantation and editor of the Society's newsletter, The Revival. Dr. Durairaj has over 20 publications in international journals, which includes being a co-author of a book chapter in an international surgery. Dr. Manoj and his team have successfully performed the first heart transplant in Pune. He has pioneered the heart transplant program in Pune by establishing 2 centers for heart transplantation. As the program director of Department of Heart Transplant at Sahyadri Hospital, he has performed the first heart transplantation in Nagpur in June 2019. Dr. Manoj has recently mentored Dr. Anil Jain and his team at Epic Hospital, Ahmedabad in conducting their first heart transplant. Recently, Dr. Manoj and his team performed the first successful left ventricular assist device in Pune, wherein the left portion of the heart is replaced with mechanical pump. So, we have such an eminent speaker today. I request Gitanjali Madam to take over the further.
Thank you, Dr. Ostwal. So over to you, Dr. Durairaj. And I also request you that we are very eager to listen to your talk. But after the talk, I would be very happy if you send in a nutshell the write-up about your talk to IMA Pune, so that those who cannot attend today's webinar will be also benefited from your lecture. Okay, thank you very much, and over to you.
Sure, thank you. At the outset, I'd like to thank IMA Pune President Dr. Varyani, the Honorary Secretary Dr. Gitanjali Sharma, the Honorary Secretary Dr. Kedar Patil, and also AstraZeneca for having me over, and thanks Dr. Oswal for a wonderful introduction. I'll be talking to you about delivering life-saving heart failure treatment. Are we on the right track? It's very important for all of us to note that heart failure is, has reached epidemic proportions in the country. The Trivandrum Heart Failure Registry, which is the largest registry for heart failure patients in India, has clearly shown that after the first admission for heart failure, the mortality rate, if not treated, is almost 22%. So heart failure is a growing public health problem in the world as well as India. It has a very high morbidity and mortality, especially once the index admission for heart failure occurs. And it is the #1 cause of hospitalization for patients above 65 years. Now, hospitalization for heart failure is projected to rise by more than 50% over the next 25 years. And mortality is also going to be very high. 5-year mortality is more than 50%, and the mortality rate increases each time the patient comes for admissions for heart failure. So we have to be very clear that the heart failure, the stages of heart failure have to be clearly defined to all of us. The first stage is stage A, that is basically structural heart disease. That means the patient has got coronary artery disease, which could be mild, which could be moderate, and then it progresses into severe coronary artery disease. And that is where we get into the picture, because the patient could have, pre-existing problems in stage A, like existing hypertension, essential hypertension, diabetes mellitus, that could predispose the patient to get into ischemic heart disease. And what happens over a period of time is, in this stage, significant coronary artery occlusion, once it occurs, that could lead to myocardial infarction. And over a period of time, the LV function, if not treated properly with adequate revascularization, either with a PTCA or with a CABG, the patient can progress into a heart failure situation where the LV function becomes poor. So this is the sequence of events where the patient has a structural problem, that is stage
You,
A.
Dr. Duraraj, can you share your slides, please?
Oh, I thought I'm sharing it. I'm sorry. Just 1 second.
Your screen, please.
Oh, really?
Okay.
Can you see it now?
Uh, 1 minute, please.
Can you see it now?
Just a moment.
Yes.
Yeah, now it is clear.
Oh my God, I'm sorry. Thank God you interrupted me. Otherwise, I carried on and on. Okay. So now you can see the slides.
Yes, sir. Yes, sir.
Yes, sir.
Okay. So on the left side is stage A. It's a structural heart disease. Anyway, we are not too late in the talk, so we have not missed out much. So what happens here is, this is where people like us in the OPD practice, general practice, should play a very crucial role for these patients, because these are patients who have got hypertension, diabetes mellitus. They can progress into significant problems later on, maybe with renal disease, with coronary artery disease, with cerebrovascular disease. So this is the stage when all of us should be getting involved, rather than allowing the patient to get into stage B, stage C, and then end stage heart failure, wherein people like me get involved for a heart transplant or a mechanical circulatory support. So stage A is very crucial in clinical practice, where we can prevent the patient from getting into a problem of repeated myocardial infarctions or uncontrolled diabetes mellitus. This is very important, stage A, for all of us in OPD practice, to give a lifestyle modification, to see the sugars are controlled, to see the pressures are controlled, so that, and dyslipidemia is controlled, so that the patient doesn't progress into stage B. Now, stage B is when the patient has significant coronary occlusions. He comes with acute coronary syndrome, myocardial infarctions, where we might be necessitated to revascularize the patient with either angioplasty or bypass surgery. If that does not happen in time, the patient's LV function goes down, and the patient then gets into stage stage C, where they have repeated attacks of heart failure. Now, we should know this, that 70% of heart failure patients, the reason is ischemic heart disease, that means coronary artery occlusion. And most of these patients, almost 80-90% of these patients, the pre-existing problem is essential hypertension and diabetes mellitus. So if in stage A we are able to control this, we will be able to control all these stages and prevent all that mortality, morbidity, and all this conversation from occurring. Now, this is very important in stage C. Many of us feel that, okay, stage D is where they need to refer a patient for heart transplant. This is called end-stage heart failure, where all medical, surgical, pacemaker treatment has failed. So this is stage D, that means refractory heart failure, when nothing can be done except for a heart transplant or a mechanical circulatory support. This is where people like me get in, where we have advanced heart failure therapies, including in my OPD, I have an ECP machine, I have a heart failure counselor, but all this can be tackled in stage C. And this is where patients should be referred to the advanced heart failure clinic, where we can prevent the patient from going into stage D. So this is an important noting point that any referral physicians who are hearing this, cardiologists who are hearing this talk, we need to ensure that the heart failure clinic is an important paradigm in this stage C, so that the patient is not referred very late, because as I'll show you in a few slides, that end organ damage can happen. Now, there are some things like guideline directed medical therapy. Now, guideline directed medical therapy, which includes Forxiga or dapagliflozin SGLT2 inhibitor, which I'll be talking to you a little later, includes ARNI, SGLT2 inhibitors, MRAs, and beta blockers. Many of us don't know so far that these guideline directed medical therapy should be started for heart failure. So I will use this platform and this talk to educate people that guideline directed medical therapy should be started in this stage C as soon as possible. And believe it or not, only 9 to 20% of people are still ensuring that any patient with heart failure has guideline directed medical therapy. So what do the guidelines actually recommend? The European guidelines, the American guidelines, what do they recommend in this day and age for heart failure? Now, the management of patients with heart failure with reduced ejection fraction should include an ACE inhibitor or an ARNI. I would say ARNI is, a molecule sacubitril valsartan, where this molecule should be considered even above an ACE inhibitor like enalapril or any of these molecules. The second molecule, which is a pillar of heart failure at the moment, is beta blockers, which can be either bisoprolol, it can be metoprolol, carvedilol. MRA is like eplerenone or aldactone. This is the third pillar. And then the focus of our talk, which is SGLT2 inhibitor, either dapagliflozin or empagliflozin. This has changed the game for patients with heart failure with reduced ejection fraction, moderately reduced ejection fraction, as well as preserved ejection fraction. So this class of tablets is very, very crucial for heart failure. And this is the first line of treatment for us. Then loop diuretics, if the patient is what we call a wet patient, that means he has congestion, pedal edema, congestive heart failure, we have to use something like diuretics like Lasix or Diator, torsemide or furosemide. So all that comes under loop diuretics. Now, the other the classifications are like if you have an ejection fraction less than 35%, QRS more than 130, then we have an implant for cardio defibrillator, cardioverter defibrillator, which is a pacemaker, which basically compensates a good rhythm and prevents the dyssynchrony which happens. So the right atrium, the right ventricle, and the left ventricle are completely in dyssynchrony. That means the rhythm does not allow the cardiac output to happen. So this allows the rhythm to settle down so that the cardiac output is maintained. So this is a class 1 indication if the QRS is less than 130 ms. And if it is patient is in sinus rhythm, LV ejection fraction less than 35%, QRS more than 130, then we have to put something called a CRT D and a pacemaker. So these are very important for us to understand that in a heart failure patient, all these modalities are there, including at the end, if all these modalities fail, that means medical treatment fails, the pacemaker fails, whether it's ICD or CRTD, then we have to go in for a heart transplant or mechanical circulatory support. I'm sorry, I need to correct myself that if a patient has repeated ventricular tachycardia, then a defibrillator needs to be put. This is what I was telling you about, that is cardiac resynchronization therapy, where the desynchrony in the heart is corrected by a CRT. So that indication is when the QRS is more than 150 ms, that is a class 1 indication to put this combo device. What about the American Heart Association and the American College of Cardiology guidelines 2022 suggests that first we need to obviously establish a diagnosis. This can be done easily with a 2D echo. It also can be done by biomarkers like NT-proBNP, which we have in our OPD. And these are the things which we need to first check whether the patient is in heart failure with reduced ejection fraction, moderate or preserved ejection fraction. You address the congestion, and immediately following that, you start the guideline directed medical therapy. And again, the same four pillars: SGLT2, beta blockers, MRA, and RB. And this is a class 1A indication. This is also important that all the therapies should be started within first 3 to 4 weeks. It should not be like we started within the first 3 or 4 months. 2021 European Society guidelines again state that SGLT2 inhibitors should be given irrespective of so many other problems. So sometimes beta blockers cannot be used in a heart rate less than 60, 70. MRA cannot be used when the potassium is high. Diuretics, of course, there is a thing that you should not dehydrate the patient. But SGLT2 inhibitors can be used irrespective of all these parameters. Now coming to the focus point of dapagliflozin, which we are talking about, that is Forxiga. Dapagliflozin has a trial which we call a DAPA-HF trial. It is the dapagliflozin and prevention of adverse outcomes in heart failure trial. So there were 4,744 patients enrolled. The inclusion factors were ejection fraction less than 40%, elevated NT-proBNP levels, and here it's important to note that many of the molecules sometimes are not used when the eGFR is low, but here we can go down to more than 30 ml eGFR. That is, like even a patient with borderline CKD, we can use this molecule. Now you do a the randomization was done between a dapagliflozin and a placebo. The median follow-up was 18.2 months. What was the primary endpoint? The study was noting whether the patient died of cardiovascular death or had any admissions for worsening heart failure or an urgent heart failure visit. There were many secondary endpoints which include symptomatology. Very important for us. The first thing which I look at when I treat a patient for heart failure is, has the symptoms improved? Sometimes the numbers don't improve, the ejection fraction doesn't improve, but a patient who's vomiting, who's anorexic, who's continuously like a cachexic patient, because of the congestion in the gut, he's unable to eat or she's unable to eat. The first thing they say is that I can eat, I've started putting on weight, and that is symptomatology. So this Kansas City questionnaire is very important in my OPD practice also, where I note that symptomatology of the patient has improved. Now, when you look at these factors, DAPA significantly reduced the risk of cardiovascular death as well as worsening heart failure in patients with reduced ejection fraction. And there was a 26% relative risk reduction by using this molecule of cardiovascular death or worsening heart failure. If you note the first slide which I showed you, there was 50% mortality at 5 years. Now, if you can reduce that mortality by starting this molecule, and the statistically significant, the graph starts diverging even on day 28. So day 28 is the day when actually the reverse remodeling starts happening in the heart. The LV volume, that means the LV size comes down, systolic and diastolic. The left atrial size comes down. Again, volume indices have been checked by echo, by cardiac MRI, by Swan-Ganz catheter. All this has shown that the effect starts within the first 28th day. That means 28th day it starts. So the earlier we start this molecule, the better it is for the patient over a period of time, because it reduces cardiovascular mortality and worsening heart failure symptoms to the tune of almost 30%. So all-cause mortality also is reduced by 17% when you look at compared head-to-head with a placebo. When you look at the other endpoints, you'll find that many of these patients, regardless of the diabetes mellitus. Now, this is a molecule which is an OHA. Many people would think that, okay, we cannot use it for a patient who doesn't have diabetes mellitus. That is a wrong concept. We can use this molecule for patients without diabetes mellitus. Some of the studies actually had 52% patients who didn't have diabetes mellitus, and in those patients there were no episodes of hypoglycemia. In fact, this forest graph clearly shows that many of these patients were normoglycemic and pre-diabetic state, but not into type 2 diabetes mellitus. And if you see the adverse events in both the groups, you'll find that whether it's diabetes or non-diabetes, the adverse events remain the same. The major adverse events, according to me in my OPD, has been not hypoglycemia, but urinary tract infection, because the sugar goes through the urine. So I have had to discontinue this molecule only because of urinary tract infection and dysuria. But none of these other adverse events I have seen in my OPD practice. So when you look at the empagliflozin, which is again a fantastic molecule to use, both of these molecules can be used in heart failure. There is a heart failure hospitalization reduction by 30 to 35% using both molecules. If you look at the all-cause reduction, DAPA is a little better, 17%. And also when you look at the Kansas City score, the symptomatology is better. Now, when you look at the cardiorenal complications in the treatment of cardiorenal complications using this molecule, when we have a patient with a low cardiac output, what happens? So this is a patient who's genetically predisposed, environmentally predisposed, has got essential hypertension, diabetes mellitus, because of various reasons. The maybe dilated cardiomyopathy, maybe ischemic cardiomyopathy, restrictive cardiomyopathy, various reasons, the heart function goes down. What happens? The patient goes into low cardiac output, has inflammation, arterial calcification, endothelial calcification. Over a period of time, there are few things which happen in the body. Chronic hypoperfusion. There's also increased venous pressure. That is something which we should be aware of. The increased venous pressure, especially in the abdominal cavity. And what happens to the kidney during that point? So target organs start getting damaged. So there is a patient who has normal kidney. Suddenly, over a period of time, that progresses into CKD because of this chronic hypoperfusion, as well as increased venous pressure in the kidney, and they develop chronic kidney disease. So what we call is cardiorenal syndrome. When we start using these molecules, we find that over a period of time, the cardiac output actually improves because of this molecule. It has got a mechanistic action on the heart, and because of that, the LV function improves, the preload reduces because the free water clearance is there. Since the cardiac output improves, the renal function improves, and the slide which is there in the eGFR slope, that means the sudden decline is reduced and the eGFR slope is reduced over a period of time. So this study, which is called the DAPA CKD, basically is a gist of what I was telling you about. They studied the composite endpoints, a patient who had CKD, and they found that, what are the composite endpoints? Sustained more than 50% eGFR decline, end-stage kidney disease, renal or cardiovascular death. And they found that the all-cause mortality was also checked. When you look at this figure, numbers needed to treat, the less the numbers needed to treat for a study, the more significant is the impact of the molecule. That means the clinical effect of the molecule is much, much better when the numbers needed to treat in the study is less. So only 19 patients, 19 was the number. So it was a clinically significant impact on the patients. So the primary endpoint, there was a 39% relative risk reduction. All-cause mortality, there was a 31% relative risk reduction. So the study was actually terminated early because of the overwhelming efficacy of the molecule. So in a patient with CKD also, this molecule makes a big difference in reducing the cardiovascular death as well as the death because of end-stage renal failure or any renal issue which is causing mortality. Now, when you look at the baseline of renal or cardiovascular death according to heart failure, so there was no history of heart failure in certain patients, but or a history of heart failure in both the sets of patients using dapagliflozin SGLT2 inhibitors over a prolonged period of time, almost up to 3 years. They found that there's an improved survival benefit using this molecule as compared to a placebo. And the same thing, primary endpoint, irrespective of the diabetes or no diabetes, there was a relative risk reduction in any of these endpoints, especially in eGFR decline. And as I told you, this is because you have improved cardiac output because of this molecule. So I'll just not get into these details, but very important for us to understand, how do you start the guideline-directed medical therapy? Should we start it slowly or should we do it fast? When we start guideline-directed medical therapy, what happens to a patient with heart failure? Again, the previous slide, 50% 5-year mortality rate. without any treatment. But when you introduce a comprehensive therapy, that means GDMT, ARNI, beta blocker, MRA, SGLT2 inhibitors, what are you giving? You're adding actually 13 years to the patient's life, which was not there before. So a patient whose survival rate may have been 1 or 2 years now can survive 13 years because you added this treatment. And this treatment should be started very early. According to me, in my practice, I started as soon as the patient gets even admitted. As soon as we stop the dobutamine, the NORAD, we start IV therapy stops. I initiated within 6 to 8 hours. So Forxiga is started as a first treatment even when the patient is in the ICU. So that is how early I start. And before the patient gets discharged, I ensure that they should have at least 2 to 3 of the molecules on board. Because over a period of time, we'll understand that if we delay like this, you start an ERB, then you start a beta blocker, MRA, ARNI. These used to be done much earlier. That means you take around 3 to 4 weeks or 3 to 4 months to start all this treatment. That is not how it works. Now we do something called rapid sequencing, which was propagated by McMurray in the circulation 2020. Step 1, a patient comes with heart failure, you start beta blocker, SGLT2 inhibitor. Step 2, within 1 or 2 weeks, start ARNI. Then step 3, you start with MRA. So within the first 3 to 4 weeks max, we have all the 4 pillars of heart failure on board. It's very important for us to understand that many of these patients have got anemia, many of these patients have got atrial fibrillation. All these also have to be corrected simultaneously. So when you look at the originator brand or a generic brand, what is the difference? Now, AstraZeneca is obviously the originator. When you look at a lot of generics have come to the market. So what are we comparing? Are we comparing apples to apples, oranges to oranges? Are we doing that? No. When you look at the pharmaceutical equivalents to bioequivalents, bioequivalents to therapeutic equivalents, all are totally different. So we should be very clear that when we are using a molecule, one, the bioavailability, bioequivalence of the molecule should be top notch so that the patient gets the best outcome. So when you look at Forxiga, we have the crystalline form, we have it in a propanediol monohydrate form. The other DAPAs, at the moment, we don't know. So this molecule has been US FDA approved, DCGI approved. That means the one which is in India. And obviously, it has been studied extensively as compared to the generic molecules which are coming now. And also a lot of data points we need to understand that compared to generic, the cardiovascular events could be higher. So for example, if you, there's a trial in the US where they compared a generic with innovator statin. They found that the probability of the patient having a 31% cardiovascular event is much more when we are using a generic as compared to a innovator brand. The same thing with stent thrombosis. When you use a generic clopidogrel and the innovator brand, they found the chances of stent thrombosis there. So it's always better to have the innovator brand on board as compared to a generic brand. So I would like to summarize so that, I think we are just 1 minute out of 2:30. Dapagliflozin. So this class of molecule, SGLT2 inhibitor, dapagliflozin or empagliflozin, has been used in heart failure with preserved, reduced, moderately reduced, and preserved ejection fraction. So all classes of heart failure you can use blindly. You can use it up to the eGFR of around 30. So that's essential. And it has shown significant benefits in composite endpoints like cardiovascular mortality, all-cause mortality, whether it's type 2 or non-type 2 diabetes mellitus. So 18% relative risk reduction in cardiovascular death, 17% in all-cause mortality. When you look at the renal dysfunction, it shows that 31% relative risk reduction has been there, reduced in a patients with compromised renal function. And the third main important point is that we should use the innovator brand because we don't know about the bioequivalence of the generics, and there could be a therapeutic challenge in using generic brands. Thank you very much to IMA Pune and AstraZeneca for having me over. Maybe a couple of questions. I think if possible, with the permission of the chair. Otherwise, we are okay. Thank you.
Uh, Thank you, Manoj. Thank you, Manoj sir, for very excellent talk on the heart failure management and very clear message that guideline directed therapy should be started as early as possible, and role of dapagliflozin in patients with heart failure. And any questions, please post in the chat box, or you can ask.
With you, Sachin.
Yeah, that's okay. So, Manoj, it was very excellent talk, and really many insight and learning points on the heart failure management. So, I request Dr. Varyani sir to felicitate Dr. Manoj sir.
Thank you, sir, for your excellent talk.
Thank you.
Please accept our token of appreciation from IMA Pune.
Sure, sure. Received, sir, virtually.
Thank you, sir. Thank you. And also diary, sir. IMA Pune diary.
Oh, lovely, sir. Lovely. Thank you so much, sir.
Thank you, sir.
Appreciate it. Appreciate your time.
Thank you. Thank you, Manoj. So, next talk is Dr. Priya madam. Priya madam is.
Hello, sir. Priya madam is busy. Dr. Suhasirinde will take us now. There is a slightly change in.
Sorry, who is present?
Dr.
Suhasirinde.
Yeah.
Okay, sir. So, next talk is by Dr. Suhasirinde, sir. CV. On Frogzirga, a class apart in SGLT2 in anticipated journey. He's a well-known physician, diabetologist in city of Pune. So just 1 second. Actually,
Any questions हो गए इसका विचार
sorry for the delay because we had prepared with this biodata of Priya madam. So Dr. Suhasirinde, sir, he has done MD medicine from Sassoon General Hospital in 1985. So he is ICMR research fellow in diabetes, postgraduate diploma in diabetes from the University of Newcastle, Australia in 2006. Practicing as consultant for last 35 years. Very vast experience in diabetes, having own diabetic center and insulin pump clinic by name of Akshay Hospital, Karve Road, Pune. Active participant in various CME at international and national and state platforms like RSSD and Apicon. Chapter in diabetes yearly book, Micro Labs. He has authored in 2008, 2009, and 2010. Consecutive 3 years, he has authored the chapter in diabetes for the yearly book by Micro Labs. Chapter in Medicine Update API in API's Association of Physician of India in 2018, 19, and 20. So this is also consecutive 3 years in update. He has authored a chapter involved in phase 2, phase 3 clinical trials in diabetes. Few of them are international study, IDPMS international study 2010, landmark national study ADA 2021. 6 publication in scientific journals, invited for poster presentation in intensive glucose monitoring in Betsa, Baltimore in 2016. technology meet. So, and he has received social awards also, many of the social awards. Out of which, for Diabetes Mitra, he has received this Diabetes Mitra award in 2015. So, here from Dr. Erende sir. So you can start, sir.
Hello. Hello.
Erende sir, you can.
Yeah, I'm there.
Yes, sir.
Would you allow me
Yes.
to share my screen?
Yes, sir. Your co-host, so you can share your screen share.
Yeah. I hope that the screen is seen,
Yes, sir, visible.
and I also hope that
Yes,
voice is clear and audible.
yes, sir. Your screen is visible. You can.
Thank you, IMA, for the kind introduction, and once again a welcome to all my friends who are participating. I will be brief about the description of dapagliflozin and the utility in clinical practice. We already are aware that chronic kidney disease, type 2 diabetes, and heart failure are interrelated, leading to a vicious circle of cardiac, kidney, and metabolic risk. We also know that, forget the figure which you are seeing right now on the screen, the latest figures are more threatening and bad compared to what you see on the screen. Now in the world, we are not looking at 476 million as you see here, but we are looking at 543. So not 47 crores, but 54.3 crores of known diabetics. The latest ICMR India publication done by Professor V. Mohan in the last week only, that tells us that the number of diagnosed diabetics in India is 10.1 crore, and the number of pre-diabetics is 13.6 crores. It is more dangerous to know and apprise that more than half of these, they don't know that they are suffering from either diabetes or pre-diabetes. You can imagine that more than 30% prevalence of hypertension and more than 50% prevalence of overweight or obesity also is something which is very, very bothersome. So the figures which will be calculated to that CKD or heart failure will be even worse than what you see in these figures. So that's what I really wanted to convey to you. We are poised at, and we are posed at a very dangerous situation for metabolic cardio-renal problems for India. The discovery of dapagliflozin, which is, I would say, a path-breaking or a wonder drug for metabolic problems and for cardio-renal protection. The discovery, as usual, was accidental or coincidental, just like the discovery of metformin, of sulfonylureas, or for that matter, many other drugs in the history of medicine. So the discovery of dapagliflozin was the ancestor is called as florizin. Florizin was isolated from apple tree bark way back in 1835 by some French scientist. It was observed that it had glycosoric effect and also thereby blood glucose lowering effect over the next few years. And the anti-diabetic effect was, let's say, looked at fairly recently. That was 1987. And it was found that florizin is an inhibitor of sodium glucose cotransporter 1, which is chiefly located in the gastrointestinal epithelium as well as the distal part of the proximal convoluted tubule, and SGLT2 receptors, which are chiefly located in the proximal part of PCT or the collecting tubule of the nephron. And florizin is something which is very bitter in taste. So naturally it was modified and the generations of the sodium glucose co-transporter inhibitors, dapagliflozin, empagliflozin, canagliflozin, rimogliflozin, evogliflozin, and so on, sotagliflozin, etc., were down the line discovered. Oxygar, which is a trade name of dapagliflozin, it has done extensive clinical phase 3 trials in a wide variety of type 2 diabetic patients. You know very well that type 2 diabetic patients come in different shades. Like, for example, they could be thin, they could be normal weight, they could be overweight or obese. They could be young, they could be old, they could be males, they could be females. You will be facing a patient who has been recently detected with type 2 diabetes, or there could be somebody who is 20, 30-year-old duration of type 2 diabetes. There will be some who are on monotherapy, some on dual therapy, some maybe on insulin, combination therapies, etc. So all these have been put to test by the Foxiga people, and then patients who are suffering from established cardiovascular disease, then established kidney problem, then people who didn't have established cardiovascular disease but with multiple risk factors like hypertension, obesity, dyslipidemia, smoking, strong family history of cardiovascular disease, all shades and colors of diabetes were looked at, and even some detailed analysis, like, for example, the DEXA scan body composition studies, and all those were done. And mind you, there are sufficient number of Asian patients also which were recruited in the Foxiga trials. Now, looking at the cardiovascular outcome trial, large part of that has been already told to you by Dr. Manoj. So I will be brief on that. This is Foxiga on the patients who are either, they are of course diabetic, no doubt, but there are some of these 17,160, 60% to be precise, who are having multiple metabolic and cardiovascular risk factors: obesity, strong family history of cardiovascular disease, smoking, hypertension, dyslipidemia, central obesity, etc. And then there are 40% of these 17,160 who have established atherosclerotic cardiovascular disease. So a history of myocardial infarct or a stroke or an angiogram proved coronary artery disease, etc. And these 17,160, very large trial really, that was randomized into 1:1 fashion. So the first patient went for DAPA-10, the second patient went for the placebo, etc. Median follow-up was 4.2 years. What was the urinary albumin creatinine ratio in milligrams per gram of creat? Less than 30%, that is less than 30 UACR, that is normoalbuminuria in 68% of patients. 23% of the patients had microalbuminuria, that is UACR between 30 to 300, and 7% of patients had macroalbuminuria, that is UACR more than 300. Renal specific composite outcomes, how were they? Depending on the UACR, normoalbuminuria, there was a 48% relative risk reduction of the renal specific composite outcome, 41% relative risk reduction in those who had microalbuminuria, and those who had a macroalbumin, they had 62% relative risk reduction in the renal specific composite outcomes. And cardiovascular death or heart failure hospitalization, again, if you stratify according to the albuminuria, those who had normoalbuminuria, there was a 10% relative risk reduction, microalbuminuria 24% relative risk reduction, macroalbuminuria 23% relative risk reduction. So dapagliflozin demonstrated consistent cardiorenal benefits in patients with or without microalbuminuria. Chronic kidney disease. CKD is the most common initial comorbidity in patients with type 2 diabetes, but remains subclinical or under the horizon. Why? Because we don't really look at it. That's very important. The standard of care by American Diabetic Association, EASD, always has been recommending that you should look for urinary albumin creatinine ratio right on the day of diagnosis of type 2 diabetes. So that is a must. But in practice, for various reasons, we really are not able to do it, but we should be doing it. So CKD is over 1.6 times more likely to manifest in patients with type 2 diabetes compared with cardiovascular disease. So if you really look at different shades here, CKD, heart failure, stroke, myocardial infarction, peripheral artery disease, and the frequency of first manifestation on the y-axis, you can easily see that 37% is the frequency of first manifestation by CKD, compared to 23% by heart failure, 17% by stroke, 14% by MI, and 10% by peripheral artery disease. Next, REVEAL CKD is a real-world study, and there are various countries which have really tried to be into this study. So USA and France, Japan, Italy, Germany. You will see that the purple part of the pie diagram is undiagnosed and the gray part is diagnosed. Very obviously, in some countries, for example, USA, it is almost 50-50. So half are undiagnosed, half are diagnosed. France, there are 94% who are not diagnosed. So generally, the system probably doesn't keenly look at microalbuminuria. Japan, 82% undiagnosed. Italy, 74% undiagnosed. Germany, 74% undiagnosed. So up to 94% of patients with type 2 diabetes are undiagnosed at stage 3 CKD. That's something which is a very dangerous statement, but it is our responsibility to look at microalbuminuria or urinary albumin creatine ratio right on the day of diagnosis of type 2 diabetes, or maybe any time down the line if the patient has not been assessed. That's something which is important. CKD was a trial which enrolled a diverse population of chronic kidney disease patients. So this was the first trial to study cardiorenal effects in an SGLT2 inhibitor, that is dapagliflozin, in patients with CKD and with or without type 2 diabetes. Because there was another trial with canagliflozin, an SGLT2 inhibitor, called as CREDENCE trial, which looked at chronic kidney disease patients, but all patients were type 2 diabetes. CKD included patients who were with diabetes and even without diabetes. Total 4,304 patients, 1:1 randomization, DAPA 10, one arm, or one first patient, second patient to placebo that way. Median follow-up of 2.4 years. All were adult patients. They were from 21 different countries. 68% of the patients with type 2 diabetes, median duration of diabetes was 15 years. Mean HbA1c at baseline was 7.1%. So they were fairly well controlled. That's what I would say. There was a broad range of eGFR from 25 to 75 ml per minute per 1.73 meters square body surface area. Broad range of baseline UACR also, so 200 to 5,000. And then 29% of the patients were taking metformin, 37% of patients were taking insulin. What was the broad observation? The primary composite outcome, that was a kidney outcome, that was the relative risk reduction was 39%. What was the specification of that primary composite outcome? There was reduction in the kidney function, that is eGFR reduction more than 40%, and sustained reduction, and then the development of end-stage renal disease, and then the renal or cardiovascular death. These were the primary composite endpoint. Then, and of course, all-cause mortality and composite of cardiovascular death or heart failure hospitalization also was looked at. So there was a 39% relative risk reduction in the primary composite outcome, 31% relative risk reduction in all-cause mortality, and 29% relative risk reduction in the composite of cardiovascular death or heart failure hospitalization. Manoj has already told you that if the number needed to treat is less, then that means that the respective drug is very efficacious as far as the endpoints are concerned. So dapagliflozin is of course very efficacious as far as the kidney protection is concerned. The number needed to treat is only 19, as you can see. Furthermore, consistent cardiorenal benefits were observed regardless of the glycemic status, because there were some patients in DAPA CKD trial who were not diabetic. So normal glucose, HbA1c less than 5.7. There were some patients who were diabetic, practically 68% patients. They had a HbA1c more than 6.5. And there were some who were in between. So A1c between 5.7 to 6.5. What was the benefit which they got? Patients who had normal glucose, that is non-diabetic patient, they had a 38% relative risk reduction of primary composite and 24% relative risk reduction of the all-cause mortality. Pre-diabetic patient, they had even a better relative risk reduction of primary composite by 63% and all-cause mortality also by 65%. Those who might actually be surprised, because if you look at the right side, diabetics, relative risk reduction is 36% for primary composite, that is renal endpoints, and all-cause mortality 26% relative risk reduction, which is numerically lesser than those with pre-diabetes. Now, how is this paradox or how is this controversial observation? Mind you, diabetic patients are clinically known, so they are being either treated by you or me. So naturally, they are on multiple, you can say, other drugs also, maybe antihypertensives, maybe antithrombotic or antiplatelet drugs, maybe statins, etc. Maybe RAS blockers also. So they are already protected, and dapagliflozin is being given on the top of that. Okay. Pre-diabetes, they are not actually, because they are in the trial now, they are being, you can say, detected as pre-diabetes, and they are probably not on adequate protective drugs. So probably they get better protection with dapagliflozin simply because they are relatively unprotected on the background. That's the situational explanation of why pre-diabetic patients are benefited better compared to those with diabetes. IMPA kidney, there is another trial. It is not only DAPA which has been tested in chronic kidney disease. As I told you, Credence had tested canagliflozin in diabetic kidney disease. DAPA CKD included both diabetic as well as non-diabetic but CKD patients, and IMPA kidney also were designed on the same lines, non-diabetic as well as diabetic patients. IMPA kidney had 6,609 patients, 2-year follow-up, eGFR between 20 to 45, or eGFR 45 to 90, that is maybe a bit better eGFR, and albuminuria, so UACR about 200. That was the inclusion criteria for IMPA kidney. Progressive chronic kidney disease or CVD, the IMPA had relative risk reduction by 28%. Hospitalization for heart failure or cardiovascular death, IMPA kidney patients had 16% relative risk reduction, and all-cause mortality, 14% relative risk reduction. However, the results were consistent in patients with or without diabetes. That's something which is important. IMPA in patients with CKD, IMPA kidney collaborative groups trial, among a wide range of patients with CKD. These are the, if you look at these features, these are the patients who are certainly akin to or comparable to some patients who are in your or my OPD. So that was a broad range of CKD patients, and IMPA certainly benefited those patients who had chronic kidney disease. Now, some select outcomes from DAPA CKD and IMPA kidney trials are compared here. So this is DAPA CKD 4,304 patients, IMPA kidney 6,609 patients. Primary endpoint, DAPA CKD composite of more than 50% sustained eGFR decline, development of end-stage renal disease, that is need of dialysis or renal replacement, or sustained eGFR decline to less than 15, or renal or cardiovascular death. IMPA, composite of more than 40% sustained eGFR decline, and of course, again, development of ESKD, renal or CV death. DAPA CKD, there was a 39% relative risk reduction. Number needed to treat it is only 19, as we have already shown. With IMPA kidney, numerically lesser benefit, 28% relative risk reduction. Number needed to treat is relatively more, 27. So, indirectly, DAPA is more efficacious in CKD patients compared to IMPA as far as these observations are concerned. All-cause death, 31% relative risk reduction with DAPA, 13% relative risk reduction with IMPA, lesser again. And composite of cardiovascular death, heart failure, 29% relative risk reduction with DAPA, only 16% with IMPA. So numerically, DAPA is superior to empagliflozin in kidney protection. Oxiga is a recommended first-line therapy for patients with DKD independent of HbA1c, that is glycemic status. So this is the kidney disease improving global outcomes, or KDIGO. SGLT2 inhibitors alongside metformin are recommended as first-line therapy in patients with type 2 diabetes and chronic kidney disease. American Diabetic Association, SGLT2 inhibitors should be used in people with eGFR more than 20. Once initiated, should be continued until initiation of dialysis or transplantation. So that's a very profound statement in diabetic patient. American Diabetic Association pertains with diabetic patients. So they have recommended that those patients who have features of chronic kidney disease, either reduced eGFR or albuminuria, you should certainly use drugs like dapagliflozin till the time the eGFR is not less than 20. That's the indirect way of putting it, until the patient goes for dialysis or transplantation. Heart failure burden is quite huge. Heart failure affects 64 million people worldwide. Now, as I told you, the number could be even higher. Heart failure is the #1 cause for hospitalization in people who are more than 65-year-old. 5-year mortality rate is nearly 50% in patients with heart failure. Heart failure hospitalization is projected to rise by another 50% in the next coming years. Mortality significantly increases after each heart failure readmission. DAPA HF trial, 4,744 patients. I will just read out the features because Manoj has already delved into the details. The composite of cardiovascular death, worsening of heart failure hospitalization, and urgent heart failure visit were the primary endpoints. Baseline characteristics, as you can see, the biomarker NT-proBNP, 1,437 picograms per ml, 31% average LVEF, that is reduced heart failure with reduced ejection fraction. 55% of the patients were without diabetes. Again, a feature of DAPA HF, and 41% patients had a eGFR which was less than 60, that is grade 3 chronic kidney disease. What was the observation? The relative risk reduction of CV death or worsening of heart failure, 26% relative risk reduction or 4.9% absolute risk reduction. Cardiovascular death, 18% relative risk reduction, and worsening of heart failure, a very remarkable 30% relative risk reduction with dapagliflozin. So, and add to that 17% relative risk reduction in all-cause mortality. SGLT2 inhibitors in cardiorenal protection, again comparison of Foxiga and EMPA, that is DAPA and EMPA. Glycemic control, new onset diabetes with DAPA, there was a 32% relative risk reduction of you can say new onset of diabetes development, that is of course pertaining to pre-diabetic patients. EMPA also improved 14% reduction in that development of diabetes from pre-diabetic status, but 14% is certainly lesser compared to 32%. All-cause mortality in CKD, 31% relative risk reduction with DAPA, 13% reduction with EMPA, again not significant. Cardiovascular death, heart failure, hospitalization in CKD, 29% relative risk reduction with DAPA, only 16% with EMPA. Heart failure hospitalization in primary prevention and CV death in heart failure, again more numerically impressive with DAPA compared to EMPA. Safety across the spectrum, so different trials. Declare me, I have shown you 17,160 patients, 60% patients with multiple cardiovascular risk factors, 40% patients with established heart disease, DAPA CKD, and then the DAPA HF trial. So the side effects like volume depletion, renal adverse events, fractures, amputations, hypos were related, certainly less. Very subtle risk of diabetic ketoacidosis, but you should be cautious about hydration, avoiding long fasting, avoiding too much of carbohydrate cutting or alcohol, etc. Genitourinary mycotic infection certainly remains a risk because all gliflozin will give you glycosuria that raises the risk of genitourinary mycotic infection. Again, critical instruction and punctuality about personal hygiene that will certainly reduce the incidence of genitourinary mycotic infections. Again, are all the dapagliflozins same as Foxiga, and I can always tell you that they are not. Dr. Manoj has already told you about the important differences between the original dapagliflozin Foxiga and the generics. Cardiovascular renal outcome trials like DECLARE-TIMI, DAPA HF, DAPA CKD in various patients, okay, with type 2 diabetes, DECLARE-TIMI, the heart failure, the cardiovascular days, the renal endpoints, they were certainly better with Foxiga, not with any other brand. DAPA HF, few patients diabetic, 45%, 55% patients without diabetes, and certainly Foxiga reduce the heart failure hospitalization, cardiovascular deaths, gave a renal protection. Also, DAPA CKD, again, the same renal protection was observed. And these slides were already shown to you just now, so I will not repeat them. The important point again to appreciate, Foxiga has moved beyond glycemic control for patients without cardiac disease, emphasizing an organ protection in type 2 diabetes, translating into the guidelines. So you can use Foxiga in newly detected type 2 diabetes if you feel it appropriate. Whether the patient has a complication or not, Foxiga will give you important reduction in glycemia. If the patient has cardiovascular or renal problems, it will automatically give them protection, as I have already shown you in different trials. So my friends, this is one drug which can be used in young patients or old patients, newly detected diabetes or long-standing diabetes, patients who are on insulin, or multiple other drugs. And it will give you either a glycemic improvement or both glycemic improvement as well as cardiorenal protection. Thank you so much for your kind listening, and thank you IMA for including me in this excellent CME program. Thank you so much.
Thank you, Erendis sir, for your nice talk. Very informative things about the SGLT2 and the Coxira and dapagliflozin and the all the CV outcomes and cardio-renal benefits of the dapagliflozin. So, any questions? Please post in chat box.
Before anybody puts a question, I will
So, thank you.
in addition of one very recent observation, dapagliflozin can be used in patients who are just now getting discharged from the hospital for acute myocardial infarction, or maybe after discharge also it can be started. A huge Korean observation has critically shown that those patients who are put on SGLT2 inhibitors at the time of acute coronary syndrome or myocardial infarction, their outcomes over the next 1.5 to 2 years, as far as repeat ACS or maybe cardiovascular death, especially, and development of heart failure, all these are better protected against these complications. So the major adverse cardiovascular outcomes are better for SGLT2 inhibitor users like dapagliflozin users or Coxira users compared to the other anti-diabetic drugs, even in post-myocardial infarction situation.
Sir, there is one question from Dr. Sagar Sarunke, sir.
Yeah.
Regarding how it protects kidney. Actually, sir has given explanation, but you can summarize the things in short, sir. Regarding
Okay. Okay. The important point here is the glycosuria is the way the SGLT2 inhibitors act, but it is not only glycosuria, it is sodium glucose co-transporters. So along with glucose, there is a passage of more and more amount of sodium also, which traverses from the proximal convoluted tubule to the distal convoluted tubule. With increasing sodium delivery to the distal tubule, there is a tubuloglomerular feedback to the juxtaglomerular apparatus, and that is the reason why the afferent vessel to that respective nephron, that afferent vessel that constricts. So the pressure which is going into the vascular pressure going into the glomerulus, that is reduced because the afferent vessel, the diameter actually is reduced. So the intraglomerular pressure comes down. With the intraglomerular pressure coming down, the albuminuria comes down. When albuminuria comes down, there is a lesser likelihood of peritubular inflammation, fibrosis, and loss of nephron. So that's one of the reasons how SGLT2 inhibitors give you protection. And then there are multiple others like uricosuric effect, and then you can say better oxygen utilization and saving of ATP for the kidney function, because the SGLT2 overexpression demands a lot of ATP, so that SGLT2 overexpression is suppressed by these dapagliflozins and empagliflozins. So thereby the ATP is saved. That also gives you a better nephroprotection. And then there are multiple others, like you can say the volume improvement and the volume overload comes down, etc., etc.
Thank you, Erendis sir, for that nice explanation regarding how the SGLT2 works. So thank you, Erendis sir, for your excellent talk. I request President Varyani sir to felicitate Erendis sir, and Geetanjali madam also.
Thank you, Dr. Erendis sir, for an excellent talk as usual. Please accept it,
Sir, thank you so much, sir. Yes, sir. Thank you. Thank you.
Yes, sir.
Diary also.
Thank you, sir.
This is the diary for you, sir.
Yeah.
Thank you, sir. Thank you.
Thank you.
Thank you. Thank you. So next, Priya madam is ready. Virendra, Priya madam is ready for the talk, or should we go with the Dr. Ishwar sir? Or I can see Ravindra Setia sir. So can we start with his talk?
Yes, sir. We can start.
Okay. So, I think, sir, co-host
Sir, it's co-host.
okay.
Yes.
Sir, you can share your screen. So, uh, uh, Dr. R.K. Sethia, sir, is MBBS from BGMC Pune, also MD Medicine from BGMC Pune, practicing as a consultant internal medicine at Sethia Clinic, a member of IMA, API, RSSDI, conduct Sethia, sir, you can start your screen. So I think Sethia, sir.
I will join at 4 o'clock.
Sir?
I will join at 4 o'clock. I am with the patients right now.
4 o'clock.
Okay, sir. Okay, sir.
Please.
So, Priya madam or Dr. Ishwar is ready?
Hello, sir. Pankaj here. Priya madam is going to join. She's busy. Just bear 5 minutes.
Okay, okay. So we'll 5 minutes.
Right, right, sir.
Even Dr. After Priya madam's talk, Ishwar sir is ready?
Ishwar, he will join on 3:30 sharp. Actually, I tried him on 3 o'clock, but somehow he's busy. So he said I will start on 3:30. That is the issue. Just we will wait for 5 minutes, sir.
Okay, no issue.
Okay. Okay.
हाँ. पे ईश्वर का ये नहीं ये सर मैं सीवी हाँ
I will get it.
I'll get it.
संजय जी बोल रही है सबका सेंड किया है
Hello. Can you make Virendra Patel as a host so he can speak? Hello.
Hello.
Yes, has Priya madam joined?
Sachin sir, Priya ma'am is right now in the procedure only. So once it is done, we will update you.
So I think if Dr. Ishwar is ready, we can proceed with Ishwar sir's presentation.
Absolutely, absolutely, sir. Right,
He's
sir.
also
Right.
he will join on 3:30, sir. Sure, sir.
So
That is issue.
CTS sir is busy with the patient. Good bole sir.
No, sir. Godbole sir will join on 4:30. Just wait a minute.
Okay.
I will call you, Ishwar, sir. Just I will try again.
Try for Ishwar sir. Virendra?
Yes, sir. Hello. Yes, sir. Yes, Sachin, sir.
Yes. What about the final?
Sorry. Hello.
So meanwhile, Dr. Raju Variani sir will we have few announcements. We'll
Sure, sir.
share that.
Yeah. Good to go ahead, sir. Good to go ahead.
We have very important CME is coming up at IMA Pune. On 6th of August, we have a CME by Healing Hands Clinic. Then on 27th August, we have a CME by Ruby Hall on neurology and care. Apart from that, also on that day, we have a CME on oncology. Then on 10th of September, we have a IMA IMA Pune. It is a very big conference. All the topics, issues related to hospitals will be talked in that conference. So do join for all these CMEs and conferences. Thank you.
And now I take this opportunity to tell you about something other than academics. On 15th of August, on Independence Day, we have flag hosting at 8 o'clock. Followed by that, there will be a talk. भारतीय स्वातंत्र्याची 75 वर्षे. It is by Mr. Arvind Halbe, who is a well-known author in Marathi and Samaj Prabodhankar we call, socialist. So please do attend this program for भारतीय स्वातंत्र्याची 75 वर्षे. On 22nd of October, we also have Sahitya Sammelan organized by IMA Pune. It is a Rajyastariya Vaidyakiya Sahitya Sammelan. So all those who write in Marathi, poetry, books, stories, short stories, they all can contact me and you can join for this Sahitya Sammelan. यावेळेचा IMA प्लसचा अंक जर सगळ्यांना मिळाला असेल तर त्याच्यामध्ये 2 स्पर्धा डिक्लेअर केल्या आहेत. वन इज मराठी कविता आणि वन इज मराठी काव्यांजली आणि कथास्तू. त्या सगळ्या कथा आणि कविता पाठवण्याची शेवटची तारीख 31 ऑगस्ट आहे. यू कॅन टेल युअर फ्रेंड्स हु आर इंटरेस्टेड इन रायटिंग पोएट्री और शॉर्ट स्टोरीज इन मराठी टू पार्टिसिपेट इन दिस. वन मोर थिंग आय विश टू टेल यू, जे सरांनी सांगितलं, ऑन 6th of August we have CME. For that also there will be 2 MMC points. For 27th August CME, again there will be 2 MMC points. And for Hospicon, again there will be 2 MMC points or even more. So those who are in need of MMC points, please do register for all these activities so that you will get all the points before your renewal for this year. Thank you very much. Over to you, Dr. Sachin.
Thank you, madam. These were the few announcements. Virendra, what's the status for the Priya madam and Ishwar sir?
I'm right outside the cath lab only, waiting for the procedure to get over, sir. So, yes, sir. Yes, sir. So once the procedure is over, she'll be joining through this only. So just once it is done, I will immediately hand it over to her, sir. Right?
Yeah. Even you can check with Dr. Ishwar because he was supposed to join at 3:30. If he's also ready, you can start with him.
Yeah. Boss Pankaj sir is also trying. Yeah, and Pankaj sir also is trying to connect with Ishwar sir, but I think he's not picking the call. So they're dropping the message, sir.
Okay. Okay.
Hi.
Yes, sir.
Hi, sir. Ishwar sir just has completed his plastic. He's joining in 10 minutes, sir.
Okay. Deepen. 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 Dr. Priya madam has joined. Virendra. Virendra, Priya madam has joined.
Just a minute only. I'll just have word with Priya ma'am and get back to you.
Or Ishwar, Dr. Ishwar.
So 5 more minutes, sir. He said he will join on 3:45.
Okay. Okay.
एक मिनट. Hello. Hello. Dipen sir. Hello. Hello. Ishwar sir has joined. Ishwar sir has joined.
Yes. Yes, welcome Ishwar.
Hello. Make him co-host, sir, please. I think he
Yeah,
is
yeah.
not co-hosted.
Yeah. Deepen, make Dr. Ishwar co-host. Yeah.
Yes. Sir, you can start with introduction. Right.
Uh, Welcome, Dr. Ishwar. Ishwar is a very well-known cardiologist. He doesn't require any special introduction. Very famous cardiologist from Pune city. He has done his DNB medicine and DNB cardiology from Pune Hospital, practicing in Pune for last 13 years. He's a panel consultant at Pune Hospital, Sahyadri Hospital, Pauna Hospital, and he has his private clinic at by name Ishwar Heart Care Clinic at Shivaji Nagar. So he'll be talking on the mitigating the high risk, high thrombotic risk in ACS patient. So over to Dr. Ishwar.
Thank you, Dr. Sachin, for kind introduction. And today I'm going to touch base the most important part as far as interventional cardiology is concerned. And this message should percolate deep down because mitigating the thrombus, especially in patients with acute coronary syndrome, post is the most important aspect in interventional cardiology because the question is of life and death. So I think I'll start sharing my screen. Just a second, share screen. Are my slides visible now?
Yes, sir, visible.
Yeah, thank you. So like I said, high thrombotic risk in ACS. Now, how do we find out which patients fall into the category of high thrombotic risk? What are the repercussions of labeling somebody as high thrombotic risk? How thin is the division between high thrombotic risk and high bleeding risk? Which patient, which subsets? There are a good number of questions which are potentially unanswered, and therefore the corridor of ambiguity is quite big. And therefore, this attempt to find out the challenge in high ischemic recurrence post ACS. Now, this is a very important. This is about 1 in 5 ACS patients suffer another myocardial infarction, CV death, or stroke within the first year. Now, this is most important to understand that treated myocardial infarction or cardiovascular death or stroke within the first year. Now, that's a big number. When I tell that 1 in 5, that's like 20%. And a third of recurrent events are fatal. So you can now understand the quantum and the gravity of the issue. So this was Apollo 1 registry. 1 in 5 patients, subsequent MI, stroke or death within next 3 years. So the thrombotic risk doesn't end at the end of say 3 months or 6 months or 1 year or 2 years. Now, with clopidogrel being used very rampantly, we have seen patients presenting with late strain thrombosis, very late strain thrombosis. So late strain thrombosis is up to 2 years. Very late strain thrombosis is up to 5 years. Of course, the incidence of subacute strain thrombosis has gone down with the usage of prasugrel and ticagrelor. Ticagrelor is more used because it has a wide safety of margin, and therefore we have to understand the subsets where we want to put them on extended period of ticagrelor. So it's not like 3 months usage of ticagrelor and then shift over to clopidogrel and aspirin. What is the risk involved in it? A patient who is going to benefit with extended duration of ticagrelor therapy is the entire contention to mitigate the high thrombus burden. So who is on high thrombus burden? Yes, the answer is a big yes to it. So the clinical risk factors, now anybody who is diabetic, we all know this as they are at high risk for thrombosis, they are at high risk for instant restenosis, and their naturally high risk factor zone. Multivessel disease, prior myocardial infarction less years ago, somebody who has peripheral arterial disease, somebody who is more than 65, underlying CKD, factors, multi-disease, bifurcation with 2 stents implanted, total stent length, a longer the stent, more the chances of stent thrombosis, treatment of chronic total lesions, PCI, specific lesion, and restenosis of target lesion. Now, trust me, 90% of things that we deal factors so the burden of somebody who is at HTR, high thrombotic risk. So as an interventional cardiologist, I would say more than 90% of the patients, they would definitely fall into one of the categories. And therefore, emphasis will always be around the usage of ticagrelor for a longer duration, maybe especially in the subsets falling in the category of HTR. So this is what I have told the criteria: complex lesion, thrombotic risk, non-complex coronary recurrent. We know that if you categorize somebody into risk based on demographic or clinical parameters, they are actually classified in high thrombotic risk and they should get extended period of ticagrelor. And now again, to emphasize the point, MVD, diabetes, prior MI, primary endpoint at 3 years in patient randomized to plus a recent MI, ADP blocker, MVD, diabetes mellitus, to event of the procedure. The pattern of adherence to antiplatelet regimen in stented patient thrombotic risk score. So if you go through the risk score, diabetes mellitus, acute coronary syndrome, current smoking, creatinine clearance of and one more variable, that's PG. You have to categorize this patient based on the clinical variables that you have into 3, and you get a score. A low risk score is 0 to 2, intermediate risk is 3 to 4, high risk is more than 5. 2, 3, low risk. That's very important. The behavior of patients with thrombotic risk. So this was one more registry, sweetheart, risk factor combinations in patients. So these are all, I mean, data of humongous amount of patients who were studied. And once it comes into registry, I mean, it goes without saying that they carry a lot of weightage in evidence-based medicine. 53.5% of patients had 2 or more risk factors, and out of this patient, 20% experience CVD, MI, stroke, and 6% of them major bleeding during 3.6 years of median follow-up. So this is what I was telling, that the risk, once you categorize someone into high risk, is not going to go down within 3 months or 6 months. It's a continuous spectrum of the of ticagrelor usage is mandatory when you categorize someone as high risk patients. So again, 85% of ACS patients violate registry, angiographic high risk feature. How long risk thrombotic risk, what I have been discussing. So a retrospective cohort which included more than a lakh acute defined as migraine infarction, like I said, ischemic stroke, overall 5-year MACE was higher in patients with HTR than those without HTR. Now that goes without saying. That is 5 years of MACE. 1 year. Risk of MACE after an AMI endures over 5 years in patients with HTR. So that's the point that I was trying to bring to your notice, that okay, every patient is different. In some of the patients, we probably would stop based on their high bleeding risk. That after and it should be continued.
Ishwar, just one interruption. There is request in chat box. Voice is breaking, so I think your internet is unstable. So can you make you can stop your video sharing and just continue with voice sharing.
I think this should help.
Yeah, it's better. Voice is better now.
Yeah. So complex PCI patients who had complex PCI had significantly higher rate of MACE. So when somebody has a left main disease or a rotablator being used, calcific, long lesions, multiple stents implanted, they fall into category of complex PCI. They had significant higher rate of MACE and definite or probable stent thrombosis. If you take into account the duration of therapy, now a very important point. And this OASIS registry, recurrence of MI and no recurrence of MI, there is doubling of the risk if you have a very abrupt usage of ticagrelor and aspirin in patients who fall into high thrombotic. So nearly 1 in 2 HTR patients will experience a recurrent event within 5 years after the index event. Now that's important to understand. If you clearly see this Kaplan-Meier curve, the MACE rate in HTR is much higher than somebody who is non-HTR. And this differentiation of HTR and non-HTR is purely clinical and angiographic. So make an attempt to find out who is high thrombotic risk, who is not high thrombotic risk. And if the patient is falling into category of high thrombotic risk, nearly 1 in 2 HTR patients will experience a recurrent event within 5 years of the index event. So acute management of HTR patients with the appropriate OAP, yes, that is important to mitigate the thrombotic risk. So the drugs in our armamentarium are clopidogrel, prasugrel, and ticagrelor. Like I said, with the advent of prasugrel and ticagrelor, and with a clear evidence showing that the stent thrombosis when compared with clopidogrel is much lower, that would translate into better CV outcomes, lesser recurrent infarctions and all-cause mortality. Of course, prasugrel and ticagrelor, they become. Somebody asked me why not prasugrel and ticagrelor. I would say that CV death is better, statistically significant with ticagrelor. All-cause mortality is better, which was not seen MI, and the therapeutic index for prasugrel is much lower. So you cannot use in someone who has had intracranial problems in the past, who has had stroke in the past, whose body weight is lesser, and the incidence of major bleeding with prasugrel is more than with ticagrelor. So my personal usage for antiplatelets has been completely shifted to ticagrelor. I hardly use clopidogrel in any of my patients, especially post angioplasty for 1 year at least, and in high bleeding risk patients, I shift them maybe 2 years or 3 years down the line to the combination of clopidogrel and aspirin. So clopidogrel is not out of equation, but now, like I said, the shift over from ticagrelor to clopidogrel is happening much later in the clinical journey, and in acute situation, we are always following back on ticagrelor now. So comparison between ticagrelor and clopidogrel, like I said, there was a significant risk reduction in terms of thrombosis, in terms of major adverse cardiovascular events. Plateau trial, we all know that the benefits of extending ticagrelor after 1 year gave a better long-term MACE rates. Ischemic risk in high thrombotic risk patient extends well beyond 1 year. So like I said, after 1 year, I think Pegasus is the trial which conclusively showed that high thrombotic risk patients after 1 year also they experience ischemic events, and Pegasus, like I said, very clearly defined that if you categorize somebody as high risk, high thrombotic risk, ticagrelor 60 milligram. So acute situation, it is 90 milligram. For 1 year, it is 90 BD. And after 1 year, the dosage of ticagrelor is 60 milligram BD. Now, if the patient falls into category of high thrombotic risk, recurrent MI, MVD, long stent, complex lesion, my current practice is to use ticagrelor 60 milligram BD for at least 3 years. But of course, going through the presentation, the MACE rate can be bettered for next couple of years if you continue ticagrelor at 60 milligram. So major bleeding, if you ask, fatal bleed and ICH were similar between ticagrelor and placebo. So if you go through the trial, you may find that the bleeding risk is little more with ticagrelor, but they were all known fatal bleeding. Major fatal bleed, intracranial hemorrhages were similar with ticagrelor and placebo. So that underlines the safety for the long-term usage of ticagrelor. Ischemic risk versus bleeding risk initiated within switching from ticagrelor 90 to ticagrelor 60 at 1 year juncture can be most beneficial, is what I have emphasized some time back. Balancing ischemia versus bleeding risk. Now, this is very important. In an attempt to prevent high thrombotic risk from recurrent event, you should not pose bleeding risk in these patients. So risk assessment is a critical component. Associated risk include bleeding or sometimes overestimated. High risk patients do not receive optimal treatment. Objective risk assessment may help reduce MACE rate and fully engage the patient in the decision making. So now this high bleeding risk, bleeding on DIABETIC, bleeding diathesis, liver disease. Now you have to take into account these parameters: anemia, thrombocytopenia if somebody is on anticoagulation, second generation death, elderly female, chronic renal dysfunction, diabetes. There is an overlap between ischemia and thrombosis. But of course, like I said, prior disease, categorize somebody into high risk who is not getting into. So one major factor that has stood the test of time to categorize somebody into high bleeding risk is anemia of less than 8 to 9 grams per deciliter. Definitely categorizes somebody at a high bleeding risk. Rest of the things I think can be managed with appropriate clinical decision making. So patients with any of the predictors of bleeding were defined as high bleeding risk, and the other patients are defined as low bleeding risk. Anemia, thrombocytopenia, chronic liver disease, anemia, they get categorized into HBR, lower bleeding risk. So a practical method to look at ischemia risk is more than patient selection algorithm. So I won't go into the details of it. You just have to go through the clinical parameters and try and find out somebody who's falling into high bleeding risk or high thrombotic risk. And based on that, you can extend the dosage of ticagrelor or cut short the dosage of ticagrelor depending upon the category of the patient. So patient with any of the predictors who were defined as high bleeding risk and the 81. So in Pegasus exclusion, they identified 2 subsets. And one interesting fact that I'm going to measure bleeding by bleeding group comparing ticagrelor 60 milligram to placebo in patients with high bleeding risk and low bleeding risk. That's also an important point. In the high bleeding risk population, there was no benefit of ticagrelor in reducing the rate of primary endpoint, but there was higher rate of TME measure bleeding is one thing when it was extended beyond 1 year. In the more than 2 ischemic risk factor subgroup, ticagrelor significantly reduced CV death and all-cause mortality. So extended usage of ticagrelor can cause some bleeding complications, but like I said, they were all non-fatal bleeding complications. But of course, it is imperative to categorize them into either a low bleeding risk or high bleeding risk. The relative benefit of ticagrelor treatment varied according to the number of ischemic risk factors, with greater benefit observed in patients with low bleeding risk and at least 2 ischemic. So the balance is more than 2 ischemic risk, low bleeding risk, they are going to accrue the maximum benefit out of ticagrelor. So 34% relative risk in more than 2 risk factors and 24% all-cause mortality benefit. So that goes beyond reasonable doubt that extended usage of ticagrelor in somebody who has more than 2 risk factors is going to translate humongously in the betterment of the MACE rate. So initiate ticagrelor 90 BD PCI up to 12 months. That's going to reduce the relative risk reduction by 21%, and beyond 21, low bleeding risk and more than 2 risk factors for a high bleeding, switch over to ticagrelor. That's the take-home message. And this I am continuing until 3 years, but the data is there to support the usage of ticagrelor 60 milligram for more than 4 years. Now, the most important point now, with ticagrelor going off patent, there have been a flurry of brands coming into market. And the question that comes to my mind when I'm treating a patient with acute myocardial infarction, should I treat this patient with the original ticagrelor from the innovator brand, or we can use it with the generics that are available who are, projected as bioequivalent at least. But to be honest, I am always falling back on ticagrelor innovator brand. Brilinta is the brand that I am falling back. That's because that has been on our nerves for good. So कोई नींद में भी बोल देगा हमको कि infarct आया तो the first order that we give is load the patient with icosapent and Brilinta and initiate the cath lab, and that gives us the peace of mind because this has been time tested and there has been some science which be compared to innovator brand. There are few studies now, of course they are not head-to-head studies, but there are few studies that usage of generic clopidogrel led to more incidence of higher platelet, 26% higher complications as well, because of course bioequivalence cannot be compared with bioavailability is what so they can have complications as well. They're not necessary to therapeutic we have seen over the past 20 years or so. And without an outcome, clinical therapeutic equivalence cannot be established by any molecule. So if you do not have a clinical trial where you have compared it with placebo or with another drug which is in contention, therapeutic equivalence cannot be established, and therapeutic equivalence therefore cannot be considered as bioequivalent. So I urge all of you to, especially when somebody has high thrombotic risk, fall back to the original innovator. And like I said, it can be decrease in bioavailability or increase in bioavailability. That can lead to either increase of or increase of both things can happen because of the variance of bioavailability in ACS patients. So why it has been like a knee-jerk reaction for us to give Brilinta, because we have developed trust on this molecule. We are backed by evidence. There are so many RCTs, Plateau, Pegasus, Atlantic. There are more than a couple of huge registries which have involved lakhs of patients. And it has been approved worldwide and has more than 10 years of experience, which the bioequivalence of generic ticagrelors can be doubted upon. So when it comes to high thrombotic risk, to mitigate the thrombus, I would always fall back on to the original ticagrelor. I think with this, thank you very much.
Thank you, Ishwar, for your excellent talk and very broadly you highlighted about the ticagrelor importance of thrombotic risk versus bleeding risk in ACS patient, and definitely the guidelines extended duration of ticagrelor. You had even for the hypertension course, Dr. Ishwar had very good talk on, very well appreciated by all the participants on the ECG lecture. Thank you, Ishwar. So I request Dr. Varyani sir to felicitate Dr. Ishwar. Ishwar, you can switch on your video now. Yeah. So I request Dr. Varyani sir, President IMA, to felicitate Dr. Ishwar.
Thank you, Dr. Ishwar sir, for an excellent talk. Please accept our token of appreciation.
I think Ishwar sir has left.
Okay. Yes. Okay. Okay.
It may be coverage issue, sir. I think. Yes, he's come back.
Yes.
Thank you, Dr. Ishwar sir, for an excellent talk. Please accept a token of appreciation from IMA Pune.
Thank you very much, sir. Thank you very much. It has been always so very good talking on this forum.
Also, this diary, sir.
Thank you, sir. Thank you very much. I'll
Sir.
definitely.
Thank you. Thank you very much.
Thank you very much.
I think Dr. Priya madam had joined.
Sit here, sir. We'll do talk. Ravindra,
Yeah.
sit here. Yeah.
Yes, sir. So.
Sit here, sir. Right.
Yes, sir. I had joined. Yes. Sorry, sir. We tried to prepone your talk, but we interrupted you in your OPD. So, just to introduce Dr. R.K. Setia, sir. He has graduated MBBS and MD Medicine from BJ Medical College, Pune, practicing as consultant and internal medicine at Setia Clinic, Eroda since 1985. He is a panel consultant at various hospitals in Pune, like Ruby Hall, Jahangir, and many more hospitals. He is a member of IMA, API, RSSDI, conducted many CME programs, webinars on various topics in medicine for general practitioner and physicians as a speaker. He has attended many national and international conferences, and very well-known physician on the Eroda side and that part of CT. So to hear from Dr. Setia, rosuvastatin evidence in primary and secondary prevention cardiovascular event. So over to Setia sir. Setia sir, you can share your screen, sir.
Yeah. Thank you. Thank you very much.
So I think
Can you hear me now? Can you hear me?
yes, sir. We can hear you, but we are not able to see your
Only the-
screen. We are not able to see your screen. Slides we cannot see your.
एक share it है. Share the content. ये share content है. Okay, can you see now?
Sir, your yes, but
Can you see the slides now?
not yet, sir. Not yet.
Hello,
No, no, sir. Not yet.
from my side actually.
Sir. Potential. Sir, the screen is different. Some potent arsenal, ACS, beta blocker, statin beta blocker. Okay. Yeah, sir, we can see your slides.
Can you see now?
Yes, sir. Yes, sir.
Okay, so today's topic is actually rosuvastatin in primary and secondary prevention of cardiovascular diseases. As we all know, primary prevention means when the event has not occurred and we want to prevent the event. For example, in patients of diabetes with dyslipidemia or hyperlipidemia, these are the patients which are more prone for cardiovascular illnesses. So if we treat these risk factors, definitely we'll be able to prevent. That's called the primary prevention. And secondary prevention means already the event has occurred. Say, for example, patient has got infarction or strokes, or patient has got angina, and then we prevent the risk factors and also treat the cause so as to prevent the recurrent events or maybe cardiovascular abnormality in the same patients. So that is secondary prevention. And today's molecule is rosuvastatin in the primary and secondary prevention. We'll see that we all know of all the risk factors which are responsible for the cardiovascular mortality and morbidity, like smoking, then less intake of fruits and vegetables, sedentary lifestyle, lack of exercise, hypertension, diabetes, psychosocial factors, abdominal obesity, all, and then lipids. If you see here, the lipids in the intra study, dyslipidemia, that is lipids, almost contributed almost 58.7% as a contributor for acute myocardial infarction that's seen in Indians. So reduction in all-cause mortality, sudden cardiac death, and non-fatal recurrence of MI after MI is also proportional to the extent of heart reduction. Though we don't have, today's topic is not for the heart rate, we'll discuss, we see that if the patient's heart rate is say 100, and if you reduce the heart rate by 10 beats, we want actually optimum heart rate about 80 per minute. If it is more than that, then if you reduce it by 10 beats per minute, then you can see that the sudden death is decreased by 39%, cardiac death by 30%, all-cause mortality by 20%, and non-fatal MI by 21%. This is just the importance of heart rate in the prevention of the cardiovascular deaths. Now, what about this? What does the various guidelines say about the use of statins? The recent ESC guidelines recommend the treatment goals for low-density lipoprotein across categories of total cardiovascular diseases. We know that LDL-C is the most important molecule which is to be lowered. Nowadays, lower is the better. That is the dictum now. But if you can see, you have to categorize the risk of the patient, whether patient is a low risk, moderate risk, high risk, and very high risk. And accordingly, you have to reduce the LDL from that point of view. Low risk means the atherosclerotic cardiovascular risk is more than 1%, sorry, less than 1%. Here, the LDL goal should be around 116 or I will say 100. For moderate risk, that means young patients, type 1 diabetes less than 35 years, type 2 diabetes less than 50 years, with diabetes duration less than 10 years, and without any other risk factors, and ASCVD risk score more than 1%, less than 5%, that is moderate risk. Here, the goal of the LDL is 100 milligram per deciliter. About high-risk patients, ASCVD score more than 5% and less than 10%. The patient has got LDL of more than 190, total cholesterol of more than 310, moderate chronic kidney disease, that eGFR between 30 to 59, family history of hypercholesterolemia without any major risk factors, and diabetes without any target organ damage with diabetes duration of more than 10 years. All these patients, they come into high risk category, and here the level of LDL should be around 70, and very high risk, the level should be around 55. The ASCVD score is more than 10%. Family history with ASCVD or with another major risk factor like smoking, hypertension, severe CKD, eGFR less than 30, and diabetes with target organ damage or more than 3 major risk factors. These are the patients who come into high risk, and here the LDL target is around 50. So you categorize your patient with which category it feels, and accordingly you have to reduce the LDL cholesterol to the desired level to prevent the complications. So with 50% reduction in LDL-C, cardiovascular events reduce significantly. This is here you can see if there is a 20% reduction in the LDL-C, number needed to treat are 63, but if you reduce the LDL-C 50%, you reduce the number to 26 number you treated. So the LDL-C decision making should be based on net benefit as estimated NNT. So suppose a patient gets a myocardial infarction at the LDL level of 100, then your aim is definitely to reduce it down to by 50%, 50 or little less. So this is again 2019 ESC and ES guidelines for very high risk patients. The LDL target has changed from 70 to 55 milligram per deciliter. What are the recommendations? In secondary prevention for patients at very high risk, LDL-C reduction should be more than 50% from the baseline, and minimum LDL-C goal of less than 55 are recommended 1A. This is the grade 1A. And if the patient has got ASCVD with second vascular event within 2 years of the first episode, and there the LDL-C goal should be less than 40, and that is grade 2B indication. So the rationale for the revised lower LDL-C goals across severe risk categories is discussed here, and accordingly we have to reduce the blood LDL levels either to 55 less than or less than 40. So these are the very high risk patient I already talked about you in the previous slide. So very high risk patient, you should come down the LDL-C to as low as 40. So again, all ACS, about the ACS patient, all acute coronary syndrome patients, they should start with the high dose statin regardless of the baseline LDL-C. So this is a class 1A indication. If the LDL-C goal is not achieved within 4 to 6 weeks, then you have to add ezetimibe on top of highest dose of statin, tolerable dose of statin. You have to add ezetimibe 10 milligram along with that. Still, if in 4 to 6 weeks LDL is not coming to the desired level, then you have got now new molecule in our armamentarium, that is bempedoic acid, which 180 milligram, which can be added to statin plus ezetimibe plus bempedoic acid. And lastly, if still the LDL doesn't come to desired level, you have to add PCSK9 inhibitors, which is an injectable form, has to be given, and to bring down the LDL-C level. So this is a treatment algorithm for the ACS patients. Here you can see the goal is, or the baseline level should be less than 50% of the baseline cholesterol, or it should be less than 40. Here, atorvastatin 20 mg and atorvastatin 40 mg are supposed to be the high dose statins, or even 40 mg of Crestor is rosuvastatin, and 80 mg of atorvastatin also are used in some patients who can tolerate it. So high potency statin at highest recommended dose to give them, and then not controlled, add ezetimibe, not controlled, add bempedoic acid, not controlled, add PCSK, and come to the desired level, so that we can prevent the further recurrence. So which statin we will prefer in ACS patient? Now we have got 3 statins in our Indian patients. We use rosuvastatin, atorvastatin, and pivastatin. pitavastatin. So let us see the comparison between the rosuvastatin and atorvastatin. Rosuvastatin 20 mg and 40 mg definitely improved the lipid level as compared to atorvastatin 80 mg in acute coronary syndrome. Here you can see on the left side, the HDL increase with the 20 mg of rosuvastatin 40 mg is much more higher than the atorvastatin. And on the left side, you can see even the LDL-C reduction is much more with rosuvastatin 40 mg than the 80 mg of the atorvastatin. So rosuvastatin definitely scores over the atorvastatin in controlling the LDL levels. So this is a steroid trial actually, which is rosuvastatin 40 mg. It showed not only reduction in the LDL, but it has got pleiotropic effect in the sense it also reduces the plaque size, and as well as it also reduces the plaque burden. So here this trial actually, a steroid trial means a study to evaluate the effect of rosuvastatin intravascular ultrasound diode coronary atheroma burden. And here they have shown that almost 78% patients, they showed plaque regression, and that is very important because the plaque size, if it's more, definitely the lumen will be much more narrowed, and you can get the myocardial infarction, or you can get the acute stable angina. Now this is again in ACS patient. You can see here not only there is a plaque regression, this is actually also there is a plaque stabilization. Why? Vulnerable plaque is more dangerous actually. Vulnerable plaque actually can throw emboli with the bloodstream to the distal organs, like patient can get myocardial infarction, patient can get cerebral infarction. So stabilization of the plaque is very important. That is done by statin. The rosuvastatin is helpful in stabilization of the plaque, and as well as regression of the plaque size, which is seen with the. So this is the additional advantage in addition to lowering the LDL. So are there any mortality benefits with the statin therapy? Of course, patient has to take statin regularly to prevent in patients secondary prevention. Patient has to be adherent to the statin therapy. And here you can see if patients are adherent, definitely they have got low mortality as compared to the patients who are not adherent to the treatment. They have got worse mortality outcomes. So I always say that this is a very important thing. All healthcare professionals, they should say that you have to continue your statin lifelong. Now about the safety of the rosuvastatin, what are the various, as compared with the other statins here, you can see all the statins here, rosuvastatin, atorvastatin, and pitavastatin, which are in our Indian market. They are compared with the solubility pattern, metabolism, clearance, half-life, and the effect of food on the bioavailability. So rosuvastatin is hydrophilic. That's the most important thing. This hydrophilic salt. It doesn't have any limited. It's a non-CIP 450 stimulant, and there is a hepatic and renal clearance. Half-life is almost 20 hours, as against atorvastatin. Half-life is 1130. Clearance is hepatic. It does have CYP3A4 metabolism. It's lipophilic, and there is it has to be given on you can say at least 2 hours after the food. With the food definitely decreases the bioavailability with the atorvastatin. So rosuvastatin scores over the atorvastatin and as well as pitavastatin. So Cristor demonstrates a favorable benefit risk profile across dosage forms, right from 10 mg, 20 mg, and 40 mg, especially in muscle function. That's very important. The muscle function, that is, we know the statins, some patients, they get muscle pains, muscle cramps, and muscle fatigue. So here there is a comparison of the different statins, atorvastatin, rosuvastatin, that's Cristor, simvastatin, and you can see here the orange mark here. You can see there is as well as there is a reduction in the LDL-C cholesterol, but without any side effect, without any hepatic toxicity or renal toxicity, or even the muscle symptoms are not seen with the rosuvastatin as Cristor. So choosing the innovator molecule versus the generic molecules, you can see if you choose the Crestor as the innovator molecule, that's rosuvastatin, it has the largest clinical program from efficacy to protection and saving, as you can see here. It's the original research brand, globally extensive experience of clinical use, more than 739 clinical studies available in more than 100 countries, and almost more than 40 million clinical prescription with the rosuvastatin original brand with Crestor. If you see now various generic formulations are available in the market, but if you see atorvastatin generics obtained from multiple sources worldwide contain a methylated impurity that reduces HMG coenzyme inhibitory effects. So they are very important. Here, methylated atorvastatin impurity was highly conserved in generic atorvastatin formulations from more than 30 manufacturers worldwide. And this impurity was shown to have no inhibitory effects on HMGR enzyme activity, and the presence of this impurity is widely available in generic atorvastatin, which may compromise the global effects towards the effective management. Even the LDLC reduction will not be achieved with these generic formulations. So you have to stick to the, because we know this is a strong risk factor for the cardiovascular mortality and morbidity. So we should always go with the original brand, which has got good bioavailability. There are no impurities in the molecule as against the generics. This is a Spanish registry data, real world study on outcomes with generic versus brand name statins. Here you can see the green bar is generic statins and the orange bar is the innovator statin. Here you can see, compared to innovator statins, the adjusted probability of all-cause death was significantly higher with generics. There is almost 62% higher risk in patients with previous cardiovascular events. So poorer treatment persistence and adherence in patients on generic statins. Patients receiving generics were more unlikely to reach LDL goals. I have already alluded to this. This is about the rosuvastatin primary prevention and secondary prevention. So it is definitely a stronger molecule than atorvastatin. We have seen this. So we should use these molecules. The various indications I have told you about the when to use this molecule, at what dosage to be used, what is the low risk, moderate risk, high risk, very high risk, and what is the target of the LDL to be achieved. So if you go by these studies, definitely we'll be able to prevent our patients from getting cardiovascular events, and even also secondary prevention will be done much more effectively with this. So there is another thing I already discussed with you about the heart rate actually. So heart rate more than 80, persistent heart rate more than 80 is also a strong risk factor for the cardiovascular events. Here you can see increased sympathetic activity can lead to increased norepinephrine, can lead to increase in the beta receptors in the heart, and which can definitely increase the demand by the myocardium, oxygen demand. There will be an increase in the left ventricular afterload, increase in the ventricular diastolic duration, and decrease in the coronary blood flow. So which can all lead to myocardial ischemia, hypoxia, and acute myocardial infarction, sudden death. So here we have to use actually beta blockers, because if we use beta blockers, the sympathetic activity is reduced, the heart rate is reduced. We have to, our target is to keep the heart rate around 80 or less, and then definitely the oxygen consumption by myocardium is reduced, left ventricular upload is reduced. There is a definitely increased coronary blood flow by causing increase in the ventricular diastolic duration, and thus we can prevent ischemia and hypoxia. So here there is another molecule, beta blocker, metoprolol, here which reduces the sympathetic activity by almost, you can say, reduction in the heart rate by 14.5 is seen with the metoprolol. And what is the uniqueness about the metoprolol? It is rapidly and completely absorbed throughout the GI tract, including the distal regions. Half-life is 3 to 4 hours. excretion through hepatic route. There is no accumulation of drug in late stage secondary disease, and there is no active metabolite. So this is the Gothenburg metoprolol trial. Metoprolol consistently reduces the mortality in post-viral infarction patients at 2 years. So each and every patient of after the post-viral infarction, one must give beta blockers unless there's strong contraindication, because it has been found that there's a mortality reduction almost 36% in first 3 months. Infarct size was significantly reduced in patients treated within 12 hours, and metoprolol did not include the occurrence of premature ventricular beats or short bursts of ventricular tachycardia post-viral infarction. So sudden cardiac death also is reduced. So it's a very important molecule we have to give in post-viral infarction patients. So this is a PMD trial, reduction in mortality and arrhythmias at 3 years follow-up. Here you can see there's a marked reduction in sudden death, 42% reduction as against placebo, 45% reduction in the ventricular reinfarction, and there is a 31% reduction in mortality. So guidelines recommend long-term use of beta blockers in patients with post-MI for at least 3 years. So these are the various guidelines, and they recommend this use of this drug. So AAC guidelines, ACC, AHA, and ESC all guidelines, they recommend the use of these beta blockers in post-viral infarction. And these are the original molecules: Seloken, the once daily admission, Excel preparation, plasma concentration is smooth and uniform throughout the 24 hours, higher degree of response among hypertensive patients, better tolerability, higher beta-1 selectivity, so less side effects, and absorption is not interfered by food or intestinal foods. So today we have discussed about 2 important risk factors for the cardiovascular. One is dyslipidemia. Predominantly LDL is the ghost molecule, you can say. So you have to reduce the LDL cholesterol, and at the same time you have to reduce the heart rate to the desired level. So you have to use the beta blocker as well as the statins, high dose depending on the patients. So thank you very much for listening. Are there any questions? Thank you very much.
Sir, there are no questions in the chat box. Thank you, CTS sir, for very excellent talk on the rosuvastatin, elaborated everything, the cardiovascular benefits for primary prevention as well as secondary prevention, and the long-acting metoprolol succinate in the role of cardiovascular diseases. Thank you, sir. Thank you for your excellent talk. I request Dr. Varyani sir and Geetanjali madam to felicitate sir, CTS.
Thank you. Thank you very much.
Thank you, Dr. Setia, sir, for your excellent talk.
Thank you. Thank you. Thank you.
Appreciation.
And sir, this is a financial diary from IMA Pune.
Thank you.
Thank
Thank
you.
you very much. Thank you. It was nice to share the platform. Thank you.
Thank you.
Thank you. Thank you. So, for introduction of Sridham Gode sir, I request Geetanjali madam.
It's my pleasure to introduce our very close friend, Dr. Sridham Godbole, sir. He has done his MBBS and MD from GS Medical College and KEM Hospital. He did his DNB endocrinology from All India Institute of Medical Sciences, New Delhi. And if I'm not wrong, he was the first one from AIIMS who came to Pune and started his practice as a qualified endocrinologist in those days. He started INSTRIDE, Institute of Treatment and Research in Diabetes and Endocrinology in Pune. He is also a consultant at Jahangir Apollo Hospitals in Pune. He has co-authored Full Life with Diabetes, and if I'm not wrong, 7 editions have been published, and Madhumeha in Marathi, 6 editions have published. He's ex-editor of Journal of RSSDI. And being an ophthalmologist, I remember, and this is a very honor for me too, that he has received Dr. S.N. Cooper Award Oration from Maharashtra Ophthalmological Society in Moscow in 2011. So it's really great to have you over here, Dr. Sridham Godbole, sir, and over to you now for your talk. Thank you.
Thank you so much, Dr. Geetanjali. It's a pleasure speaking in front of the IMA, and I thank the IMA for this opportunity. I am going to speak actually on the role of dapagliflozin in reducing mortality in our patients with chronic kidney disease. And though I'm an endocrinologist, my talk is not limited to patients only with diabetic kidney disease, but in general with chronic kidney disease, because dapagliflozin benefits patients with chronic kidney disease irrespective of their diabetes status. So let us have the first slide. Now, the risks that are associated with chronic kidney disease, the mortality risks, as well as the cardiovascular risks are elevated regardless of the etiology of chronic kidney disease. So, for example, if you get nephropathy because of hypertension, there is a more than threefold excess risk of cardiovascular events and mortality. If you have IgA nephropathy, the risk increases 53%. And in fact, with diabetic nephropathy, there is a greatest risk, at least a six-fold higher risk of cardiovascular events and mortality. And as I think all of us are aware, the greatest cause of death in diabetic nephropathy is not actually end-stage renal disease, but it's actually cardiovascular disease. So in general, chronic kidney disease carries a very grim prognosis, both from cardiovascular as well as all-cause mortality point of view. Next slide. Now, there's a specific dedicated trial of dapagliflozin in chronic kidney disease. And this is a path-breaking trial because dapagliflozin, to begin with, of course, is an anti-diabetic drug. But this trial with dapagliflozin enrolled a diverse population of patients with chronic kidney disease, which included various etiologies. It was not limited only to diabetes. And 4,304 patients were recruited, and they were randomized 1:1 to dapagliflozin 10 milligram once a day or a placebo. And this was an event-driven trial, and the median follow-up time resulted was about 2.4 years. And you can see that from the eGFR range that they took patients with as low as an eGFR of 25 to around 75. So 41% of patients had an eGFR which exceeded or equaled 45, and the remaining 59% had an eGFR of less than 45. And the range of the urine albumin creatinine ratio was anywhere from 200 to less than or equal to 5,000 milligrams per gram. And the patients could continue the dapagliflozin even following the dialysis initiation. And if you can see the various causes of kidney disease that patients had in this trial, 58% of them had a diabetic nephropathy, followed by 16% with ischemic hypertensive nephropathy. And then you had some patients with IgA nephropathy, 6%. You had some patients with FSGS, some with unknown causes, 5%. And 12% who had various other causes. So a very diverse group of patients with chronic kidney disease. Next. Now, this is the first dedicated chronic kidney disease trial that demonstrated robust both cardiorenal as well as mortality benefits. And if you look at the primary composite endpoint or the outcome, it showed a 39% relative risk reduction, which translated into a very impressive numbers needed to treat of 19. And the all-cause mortality came down by 31%. And the composite of the cardiovascular death and hospitalization for heart failure was reduced by about 29%. Now, remember, this is the first dedicated CKD trial which actually looked at all-cause mortality risk and actually showed a reduction. And this is the most objective criteria that you can get. Next slide. If you look at the primary outcome, which was a composite of a sustained decline in the eGFR by at least 50%, or end-stage kidney disease, or renal or cardiovascular death, and if you look at patients and classify them as whether they have diabetes or do not have diabetes, you find that if you had a 36% risk reduction in the group with diabetes, there was an even greater reduction of about 50% in those patients without type 2 diabetes. Remember, this is an anti-diabetic drug, but it produced even greater benefits in patients without diabetes as far as the primary renal composite outcome was concerned. Next slide. If you look at the secondary renal specific outcome, which was actually the composite of the sustained GFR decline by 50%, end-stage kidney disease and renal death. Now, you're not talking of cardiovascular death over here. This is the secondary outcome. And now again, you look at patients with or without diabetes, you again find that they really do as well, irrespective of the fact whether they are diabetics or not. So 43% and 49% relative risk reduction, respectively. Next slide. If you look at all-cause mortality, which is an all-important outcome, then patients with diabetes showed a 26% relative risk reduction, whereas those without diabetes showed a 48% relative risk reduction in the all-cause mortality. Next slide. Now, if you look at the diabetes status, classify patients as those with diabetes and those without diabetes. This is just like a summary of what I just told you. The primary composite outcome was reduced by 36%. The all-cause mortality was reduced by 26%. And the composite of cardiovascular death and hospitalization for heart failure was reduced by 30% in patients with type 2 diabetes. Whereas in patients without type 2 diabetes, the figures, the respective figures were 50%, 48%, and 21% risk reduction, respectively. Next slide. If you now look at the various etiologies of chronic kidney disease and you look at the various patient subgroups, whereas if they have diabetic nephropathy or ischemic or hypertensive nephropathy or glomerulonephritis or other or unknown causes, and then if you look at the relative risk reduction of the primary outcome, you find that all of the forest plot all favors the dapagliflozin overwhelmingly. Only where the confidence intervals you can see are wide, it merely indicates that the numbers are relatively small, which makes the confidence intervals wide. But where the numbers were large, there's a very clear-cut, unequivocal benefit in favor of dapagliflozin. Even for all-cause mortality, even for the composite of cardiovascular death and hospitalization for heart failure, you find that irrespective of the various etiologies of chronic kidney disease, dapagliflozin across the board confers a consistent cardiorenal and mortality benefit. Next slide. Now, whether now you take the stages of chronic kidney disease as stage 2 or 3 and those with stage 4, and then compare the outcomes again with stage 2 and 3, the figures for the primary, all-cause, and the composite of CV death HHF is 42%, 31%, and 31% respectively, whereas at more sicker patients with stage 4 of chronic kidney disease, the numbers are 27%, 32%, and 17% respectively. So clearly it doesn't matter whether the patient is an early CKD or late CKD, dapagliflozin is going to confer benefits, both cardiorenal as well as all-cause mortality, as well as the composite of cardiovascular death and HHF. Next slide. How about tolerance? Many people are sometimes concerned about adverse events of SGLT2 inhibitors, and I think this slide should allay any apprehensions which anyone might have. Now, if you look at the important figure, which is practically important, is discontinuation due to an adverse event. You find that when you compare with placebo, the figures are virtually comparable. If you look at serious adverse events, again, you find the numbers are comparable, in fact, numerically favoring the dapagliflozin. And if you now look at certain adverse events of interest, like acute kidney injury, in fact, you find that dapagliflozin patients actually did better, though I won't say this is statistically significant, but they in fact did better as far as acute kidney injury is concerned. Any kidney-related adverse event, in fact, the numbers are smaller in the dapagliflozin group, and hypoglycemia, major hypoglycemia, of course, slightly more in, again, the placebo group. So actually, the overall adverse events of interest, actually, patients in dapagliflozin doing better, except numerically, volume depletion is more in patients with dapagliflozin. Now, the safety profile is again consistent, irrespective of your diabetic status, irrespective of the etiology of chronic kidney disease and the baseline stage of the chronic kidney disease. So I believe dapagliflozin has again come out with flying colors. like in all trials, there's no red signal with dapagliflozin as far as safety is concerned. Next slide. Now, if you compare a similar trial, it's not always wise to compare two different trials. You cannot really make a head-to-head comparison, but you had a similar trial called EMPA kidney trial with empagliflozin. And of course, the endpoints were fairly similar, whereas only the difference here in the DAPA-CKD, I told you the 50% decline was the endpoint, whereas here it was a 40% decline. Now, if you look at the relative risk reduction, only the numbers, for whatever they are worth comparing, the DAPA-CKD actually came out with better numbers, 39% relative risk reduction compared to a 28% relative risk reduction, though in fact, this criteria was more stringent compared to the EMPA kidney trial of 40%. The all-cause death, again, this is the only trial that is showing a 31% relative risk reduction in all-cause mortality. 13% relative risk reduction was not statistically significant in the EMPA kidney trial. And again, the composite of cardiovascular death and hospitalization for heart failure is 29% significant reduction for the DAPA-CKD trial, unlike the EMPA kidney trial, which showed a 16% relative risk reduction. Next slide. So between the two trials, I would say dapagliflozin trial showed a better benefit. Now, a similar, which is a related thing to kidney disease, is heart failure. And you might ask me, how are the two related? You're speaking on kidney disease, and why are you talking of heart failure? So let us see. Next slide. Now, the kidneys and the heart, they are highly closely correlated. Certain abnormalities in the heart can affect the kidneys, and abnormalities in the kidneys can cause problems in the heart. So these could be, related to genetic predisposition, or you can have various other causes like inflammation or endothelial dysfunction, or various inflammatory chemokines are sort of secreted by the heart. You sometimes have chronic hypofunctioning of the heart, which leads to decrease in the perfusion of the kidneys, and that leads to reduction in the kidney function and progression of kidney disease, or even initiation of kidney damage. On the other hand, if you move forward, kidney disease itself can also, by virtue of anemia, metabolic disturbances, volume overload, can put a burden on the heart failure. And also, when you have a kidney disease, plus you have cardiorenal connectors like RAS activation, you have various oxidative stress-related molecules, the reactive oxygen species, the inflammation, and the SRS activation of the sympathetic nervous system. You have both the kidney and the heart being related, which is therefore not surprising that the greatest cause of people with of death in chronic kidney disease is actually heart disease or cardiovascular death. Next slide. So if you can somehow reduce cardiac mortality or reduction in the heart failure, you're probably also going to benefit the kidneys. So you had a dedicated DAPA-HF trial. Again, I repeat, these patients, though dapagliflozin is an anti-diabetic drug, but this trial is for patients with heart failure and reduced ejection fraction with or without type 2 diabetes. 4,744 patients, again randomized to dapagliflozin or placebo 1:1. And all these patients had an ejection fraction of less than or equal to 40 with elevated NT-proBNP levels and an EGFR of between of more than 30. The primary endpoint was the composite of cardiovascular death or worsening of heart failure. And the secondary endpoints included either a cardiovascular death or HHF, and the total number of hospitalization for heart failure. They also had a quality of life questionnaire, and again, a secondary sort of a renal endpoint. And these were the baseline characteristics of the patients. Elevated NT-proBNP, the average LVEF was 31%, and in fact 55% of patients had no diabetes, remember that, and 41% had an EGFR of less than 60, so they also had to some degree a compromised renal function. Next slide. Now, if you look at the primary outcome, the primary endpoint, that's the composite of cardiovascular death and worsening heart failure, you find that there's a very, very robust sort of numbers needed to treat number over here. 21, it's a pretty low number. You just have to treat 21 patients more with dapagliflozin to reduce the risk of the cardiovascular death or worsening of the heart failure if they have got a heart failure with reduced ejection fraction. And you can see that these Kaplan-Meier curves separate very early on, as early as within 1 month, indicating that this seems to be primarily a hemodynamic driven effect. You can also see this is the relative risk reduction of 26%. And if you tease away the components of the composite, 18% reduction in the cardiovascular death, 30% relative reduction in the worsening of the heart failure. So this benefit largely driven by heart failure benefits. Next slide. Now, again, this tolerance, as I said, again, I won't repeat this in the interest of time, but I can tell you whether or not the patients had diabetes or did not have diabetes. Dapagliflozin was very well tolerated in both groups of patients, whether they had diabetes or not. So again, safety-wise, again, there is no red signal from dapagliflozin. Next slide. Now, if you look at the heart failure perspective, and you now look at reduction in the heart failure, you compare like I previously compared the kidney trial with empagliflozin. If you compare the similar trial with empagliflozin and you look at the various parameters, you find that again, the benefit for hospitalization for heart failure is really similar between the two molecules. But the cardiovascular death reduction is better with 18% with dapagliflozin and a non-significant 8% reduction with empagliflozin. Again, the all-cause mortality with dapagliflozin again is showing a significant benefit of 17%, unlike the EMPA group. And also you have some data on onset of new diabetes in those patients who had pre-diabetes to begin with. Here again, a very robust 32% reduction for empagliflozin, but a non-significant 14% reduction with empagliflozin. And the quality of life, if you can see over here, then by and large, I would say they are similar between the two groups. But if you look at the hard endpoints of cardiovascular death, all-cause mortality, onset of new diabetes, comparing two trials where there are some limitations, but dapagliflozin again seems to do better than empagliflozin. Next slide. Now, again, the important question, there are so many dapagliflozins in the market now that it is off patent. Are all of them same as the innovator Forxiga? Let us see. Now, if you look at actual data, if you look at evidence, remember that it's only the innovator Forxiga which has been used in all these clinical trials involving thousands of patients. Whereas really, you do not really know whether the generics would work as well because they've simply not been tested in all these large trials. Next slide. If you look at the generics, the people sometimes tend to think that just because you have a pharmaceutical equivalence, it automatically translates to a bioequivalence. And going further, people very often feel that just because the pharmacokinetics or the pharmacodynamics may be comparable, that would lead to a therapeutic equivalence in the outcomes. But this is not always so. The two really sometimes may not match, and there are trials to show that. Next slide. So, for example, if you a bioequivalent drug, let us, for example, take the original molecule, and now you have a generic molecule. Because when you talk of bioequivalence, the DCGI requires an 80 to 125% range to call a drug bioequivalent. Now, for example, if it is only 80% bioequivalent, it will still qualify, but then it may not be as effective. Whereas on the other hand, if the bioequivalence is greater, say it's 125%, then you may not know the adverse events may be more with such a drug. So it always makes sense to go with the innovator because the innovator has been actually tested in these clinical trials. Next slide. And again, you have, if you look at various parameters, if you look at the various, the chemical components, the composition, then this is dapagliflozin, propanediol monohydrate. It's crystalline, whereas most of these generic DAPAs are amorphous. Most of them are amorphous, some of them are crystalline, but you really don't know their exact chemical composition. The Forxiga, the innovator molecule, is of course approved throughout the world. The patients very often travel abroad and this would be approved anywhere in the world, whereas the generics are only approved in India by the state FDAs and the DCGI. And then you have the event-driven RCTs. As I said, the generics have not been studied. We don't know, how safe they are when you continue them in the long term. And the drug development of the innovator is always more comprehensive, whereas the generics only have to demonstrate bioavailability or bioequivalence. That's all they have to prove. Next slide. And I think, as Dr. Setia probably alluded in a previous lecture, whether the differences have been seen in clinical trials between original and generic. So if we can move forward, for example, this is a trial with statins, where you had an innovator statin and a generic statin, and you find that with the generics there was a 31% greater probability of suffering a cardiovascular event compared to the innovator statin. So I mean, why take chances, especially when even the innovator molecules actually have come down in their prices? So actually speaking, it doesn't really make much of a difference in the price. Next slide. So the important message from today's lecture, there's a need to intervene early with Forxiga or the innovator dapagliflozin to slow down the growing burden of chronic kidney disease and to transform patient outcomes, because chronic kidney disease is a major health crisis. It leads to increasing costs, mortality, and kidney replacement therapy prevalence, which adds to the global burden. The risks of both mortality, all-cause, as well as cardiovascular are increased irrespective of the etiology of chronic kidney disease. And in fact, dapagliflozin was the first therapy in over 2 decades to actually reduce the risk of CKD progression, cardiovascular events, and mortality in patients with chronic kidney disease, irrespective of their etiology. And I showed you a couple of slides on the importance of using an original molecule compared to the generics. Thank you so much for your patient listening, for your time. I hope I finished within time and covered my topic adequately. Thank you so much.
Thank you, Godbole sir, for your very good presentation on the CKD related dapagliflozin and SGLT2 uses of SGLT2 in CKD patients. So I request Varyani sir and Geetanjali madam to felicitate Godbole sir.
Thank you, Dr. Godbole sir, for an excellent talk. Please accept our token of appreciation from IMA Pune.
Please accept this financial diary. I request Dr. Lakde sir to join, please. Yeah.
Thank you, sir.
Thank you, sir. Thank you.
So, Priya madam, you are ready?
Yeah.
Yeah. Busy cardiologist. Okay.
Less than
So this is the last talk by Dr. Priya madam. So you, because of time consideration, you have to be a bit brief, madam. Dr. Priya Palimkar madam, her DNB cardiology from NM Institute. She is one of the senior cardiologists from CTO of Pune with more than 20 years of experience in interventional cardiology. She is attached as a panel consultant at Sahyadri Hospital, Nagar Road, Jahangir Hospital, NM Wadia, and Ruby Clinic. She has her own clinic at home as a home heart care at Vishrant Wadi, and from her, she'll be talking on minimizing stent thrombosis. Choosing the right oral antiplatelet is the key. Over to you, Priya madam.
Thank you, Sachin, and thank you everyone for being patient with me. There were some delays. So coming to the talk, how to minimize stent thrombosis post PCI. This is the topic for me. And I always think that as an interventional cardiologist, you can sleep soundly only and only because you know that the antiplatelet drugs are working well. And with the advent of the newer ones, the incidence of stent thrombosis has gone down considerably. So coming to this talk, we would just like to start the presentation with a example of a 75-year-old gentleman, hypertensive, smoker, having COPD, who presented with substernal chest pain. X-ray was unremarkable. The troponin was 400. He was loaded with aspirin. Now, this is the ECG which shows STT changes in inferolateral leads. These could be hypertension related or they could be ischemia related as well. And this patient underwent an angiogram which showed that he had a stenosis of 90% in the mid circumflex and 90% in RCA. And subsequently, angioplasty was done to circ and RCA. Now, after this, the TIMI-3 flow was achieved. And during this procedure, the patient was loaded with clopidogrel 600 milligrams in the cath lab. And he was also given other guideline-directed medications like metoprolol and lisinopril. He, however, could not be given ticagrelor because he had COPD and had a wheeze in the chest. And prasugrel was not an option because he was 75-year-old and there was a higher incidence of probability of intracranial bleeding. So this patient was discharged on dual antiplatelet therapy of aspirin and clopidogrel. And on the 10th day after this discharge, he got admitted again with substernal chest pain. And let's see what the ECG says now. It looks like an ST elevation, inferior wall, myocardial infarction with posterior extension as well. And this was the angiogram on the left-hand side. You can see that the RCA is occluded right from the origin. And he underwent an angioplasty again. And the right side image, you can see that the artery is now patent. So what happened to this patient? Now, this patient probably now at this time, he was, the clopidogrel was discontinued and he was given ticagrelor 180 milligrams. Watched closely for 48 hours and then discharged and asked to follow up as an outpatient. Now, this is a very common scenario. Previously, we used to see more and more of stent thrombosis, but with the advent of ticagrelor, we find that the incidence has gone down considerably. So what are the actual causes of stent thrombosis? There are patient factors, procedural factors, lesion factors, and stent factors. Amongst the patient factors, the most important is, drug compliance, clopidogrel non-responsiveness, patients with lower ejection fraction, and so on. And the lesion factors, patient having a left main bifurcation disease, severely calcified, in-stent restenosis, and so on. And stent factors are like overlapping stents, long length of the stent fractures, or hypersensitivity to the drug in the stent. Now, with the advent of imaging like intravascular ultrasound and OCT, the stent factors can very well be negated because we are actually imaging the artery from inside. We can see what are the problems. We can have a good landing zone. The stent apposition can be perfect and we can improvise on these stent factors. Procedural factors of stent under expansion or edge dissection is also taken care of by imaging. So the most important thing now remains actually is the patient factors. So if you introspect in this case, what was actually the problem was the drug clopidogrel. Probably the patient was not responsive to this particular drug, and that was the reason why he had an acute stent thrombosis. Now, when we have studied literature, there are so many trials which were done on clopidogrel resistance, and it has been found to be higher in Southeast Asians, and the range of drug resistance is 5 to 44%, which is a very large number. And even in India, the studies which were done, the Indian studies also showed a lot of clopidogrel resistance. So apart from clopidogrel non-responders, does the stent thrombosis occur in the DES era? Now, pooled PROTECT trials, stent thrombosis in modern DES era. So they have used the newer stents. This was an 8,000 plus subject trial where Endeavor, that is Zotaralumis eluting, or Cypher, that is Sirolimus eluting stents were used, and they found that there was early stent thrombosis to the tune of almost, the patients who had early stent thrombosis, they had a mortality of 33%. Those had a incidence of myocardial infarction of 75%, and cardiac death or MI was almost, the total was 93%. So, those who have the early stent thrombosis, they have a very high incidence of mortality. So on even the late stent thrombosis, they also, the incidence of mortality is lower, but yes, MI and cardiac death is also high. And so is the case with very late stent thrombosis. Now, if we see the relationship between ST timing and outcomes, it did not differ between the stent types. So cardiac death in patients with stent thrombosis at 4 years occurred in 32% compared with 2.5% in patients without the stent thrombosis. So definitely, if someone has had a stent thrombosis, the mortality chance is extremely, it's 30% odd, which is very high. And combined rates of death and MI did not differ according to the stent thrombosis timing, yet early stent thrombosis was more commonly associated with cardiac death at 4 years than the later stent thrombosis. So now coming to the point, which is the right oral antiplatelet in this situation? Now we have three. Aspirin is universal, but the second antiplatelet, we have three drugs, that is clopidogrel, then we have prasugrel, and we have ticagrelor. Now, the reversibly interaction with P2Y12 ADP receptors is seen with ticagrelor, whereas it's not seen with clopidogrel and prasugrel. It's only ticagrelor which has a reversible interaction. It has an active metabolism without having a prodrug, whereas clopidogrel is a prodrug. It has to be converted into the active metabolite and then it acts. So is the case also. The mean elimination, that is the half-life, 7 hours for the parent drug ticagrelor. It is 6 hours for the parent drug and 30 minutes for the active metabolite. Prasugrel, again 7 hours for the correlates to the clinical efficacy or safety results. So ticagrelor and its active metabolite are approximately equipotent, and that is the reason why it immediately starts acting and it has the fastest onset of action, which is what we actually need at that particular point in time. Now, if you compare the clinical outcomes as CV death, all-cause death, clopidogrel was 7%, prasugrel was 11%, and in ticagrelor it was 21%. So it's very significant. Ticagrelor showed a significant benefit of reduction in CV death by 21%, reduction in MI by 16%, and all-cause death of 22%, which is clearly much better than the other drugs, except that in prasugrel, the incidence of MI was reduced by 24%. That's the only significant point here. So the superiority of prasugrel's efficacy over clopidogrel was offset by the increased risk of bleeding. So that was the reason why there was a black box warning, and it was said that there is an increased risk of severe bleed with prasugrel, especially so in people who have a weight of less than 60 kilograms or age of more than 75 years. Also, it is contraindicated in strokes and TIAs and CABG done at least, done within 7 days of this index event. So Plato was the trial on ticagrelor, and this established the efficacy and safety of ticagrelor in ACEs patients at 12 months. And you can see that there was a separation of the Kaplan-Meier curves, and there was a definite improvement in the safety with patients who were on ticagrelor as compared to clopidogrel. Again, there was no significant difference in the total Plato-defined major bleeds. So there was a very minor numerically increase in the bleeds, but actually the p-values, there was no change. So ticagrelor was definitely and clearly more efficacious as well as safe. Now, planned treatment approach, when they did a subgroup analysis and they had two arms, there is an invasive management arm where the patient underwent PCI, and there was an arm where only medical management was done. In both the arms, they found that ticagrelor definitely was more beneficial. It had a less incidence of CV death, MI, and stroke in both the arms. So overall, if you look at the subgroup analysis, it had a relative risk reduction of 21%, which was a clearly very significant p-value. Now, the role of ticagrelor in protecting stents post PCI. Now, definitely we have seen through all this right now that this is a very potent drug. It causes a reduction in the stent thrombosis. And let us see how much. If you compare with clopidogrel, the definite stent thrombosis was only 1.3% in the patients who received ticagrelor, whereas 2% in patients who received clopidogrel. Even probable and possible stent thrombosis was much less in the ticagrelor arm as compared to the clopidogrel arm. So the stent thrombosis reduction within 30 days, the subacute stent thrombosis, there was a 40% relative risk reduction. And in late stent thrombosis, 52% relative risk reduction, which is a very large number. And that is the reason why we as interventional cardiologists feel very safe to use ticagrelor as the drug of choice for the post-PCI patients. Now, again, maybe we can skip a few slides. So ticagrelor versus clopidogrel in patients with primary PCI. As compared to clopidogrel, ticagrelor was associated with a lower rate of stent thrombosis without any difference in hemorrhagic events in patients with in hospital or outside of the hospital as well. Prevention of in-hospital cardiac arrest was another acute benefit of ticagrelor, and they found that in-hospital cardiac arrest is one of the most deleterious complications of ST segment elevation MI. And this intra-hospital cardiac arrest was rare in STEMI patients, but was associated, whenever it happened, it was associated with very high mortality. And in this, they found that patients who were treated with ticagrelor, there was a significant benefit in reducing the incidence of in-hospital mortality. So 43% relative risk reduction in patients who received ticagrelor. Now, again, the same thing, whether to use the innovator brand or to use the other bioequivalent brands, as Dr. Godbole has already mentioned, pharmacoequivalence is not equal to bioequivalence, and that is not equivalent to the therapeutic equivalence. And hence, just doing a bioequivalent study with the generic of the generic molecule with the innovator molecule is clearly not sufficient to say that the drug will work in the same way. So ticagrelor is a complex molecule with centers and 64 possible stereoisomers, and having the right stereoisomer is the key for the reversible platelet P2Y12 ADP receptor interaction to prevent the platelet activation. And are all the generic brands really checked for this kind of isomeric purity, this is very questionable, and hence there was a study which was carried out where they checked the percentage purity of different oral antiplatelet brands in India, and a study conducted in Kerala in 2020 demonstrated a wide range of variation in the actual amount of the active ingredient in the generic brands. So do these differences in and bioavailability in generics lead to clinical outcomes? Yeah, this is a very important thing. And there was a study done in Mount Sinai where they, compared the innovator clopidogrel, that was, I think, Plavix, with the generic clopidogrel brands, and they found that those who were not given the innovator molecule, they had a clearly 3 times higher stent thrombosis. Another publication in JACC found that the generic oral antiplatelets cause 65% higher incidence of high platelet reactivity. And the US FDA adverse event report found that the generic oral antiplatelets might be associated with 26% higher bleeding complications. And hence, when you look for safety and efficacy in your patient, you don't want to compromise on giving a generic brand. So there is a more than twofold increase in stent thrombosis in patients who are given oral generic antiplatelets. Now, clustering of acute and subacute stent thrombosis related to introduction of the generic clopidogrel, and that was the reason why people shifted to that. But as we have seen from the studies, we can clearly see that there is a increased incidence of stent thrombosis and a higher incidence of bleeding in patients who are given the generic brands. So 26% higher hemorrhagic complications, as I just told you. So at the end of the day, choosing the right ticagrelor is the most important thing, because the innovator brand is the one on which all the trials have been done. The Plato, Pegasus, Atlantic, Sweetheart, Treat, all these trials were done on Brilinta 90 milligrams only. And hence, this is the only molecule which has a 10-year experience. The bioequivalent studies do not have any data actually in terms of long-term studies, and hence they cannot be equated to the innovator brand just on the basis of a bioequivalent study. So in summary, stent thrombosis can occur early, late, and very late. Thus, optimal DAPT is essential. Relation between stent thrombosis timing and outcomes did not differ between the stent types. But yes, it all depended on the antiplatelet drugs. Ticagrelor is the only P2Y12 inhibitor which reduces CV mortality significantly in ACS patients, both in the medical arm as well as the interventional arm, and is indicated to provide a 48-month protection post-ACS. Bioequivalence is not equal to therapeutic equivalence, and generic equivalence may differ in efficacy and safety from the innovator, and hence we must use only the innovator, that is the Brilinta, because that is the only one which has all the robust data behind it. Thank you.
Thank you, Dr. Priya Madam. It was an excellent talk. May I request Dr. Lakde sir to summarize, please?
Yeah, Madam, very nice presentation on the how to deal with the minimizing the stent thrombosis, especially role of ticagrelor for and how should we use for all post angioplasty patients. Thank you. And there are no questions in the chat box, and already we are late. So I request Varyani sir to felicitate Gitanjali madam, and Varyani sir to felicitate Priya madam.
Thank you, Dr. Priya Madam, for your excellent talk.
Thank you. Thank
Please
you.
accept a token of appreciation from IMA Pune.
Yes, thank you.
And the financial diary, ma'am, for you. I request Lakde sir to join as well. Yeah, this.
Thank you.
Thank you, Madam. Yeah.
Thank you.
All faculty to come at least once to IMA Pune, and we'll all meet.
Thank you.
I take this opportunity to thank all the delegates who joined for today's webinar. And also I would like to thank AstraZeneca. And my special thanks to Mr. Dipen Mehta, who has given the technical support. And he has been helping us for all the webinars and also for the excellent conduction of our online certificate course of hypertension. Thank you, Dipen, for all your help. Over to you,
madam. Thank you. Thank you, madam. So we can leave the meeting.